I'm making it live on YouTube.
Okay.
We are live on YouTube. I'm starting the cloud recording.
Okay.
So we are live on YouTube and also started the recording. So this is Ranjit Sahu, Marketing Head with Walter Bushnell. Welcome you all to this live webinar. So Accluge Obstetric and Gynecological Society invites you for the webinar on IUGR updates. All the panelists from across the country have joined for this beautiful webinar on this Thursday evening of 2nd June. With this, I hand over the session to Priya Kadam ma'am, the president, to take it forward from Accluge Obs and Gynae Society. Priya ma'am, over to you to take it forward.
Okay. Thank you, Walter and Bhushna. Manisha? Good evening, everyone. Am I audible, Manisha?
Yes, ma'am.
Okay. Good evening, everyone. I welcome all the faculties and online delegates for this webinar on IUGR updates. Accluge OBGYN Society has always tried to boost the knowledge of all the participants in their day-to-day practice. I welcome our guest of honor, Dr. Sneha Bhuyarmam, and also welcome today's chairperson, Dr. Anjali Jamma ma'am, Dr. Madan Kamble, and Dr. Rajiv Rane sir. I also welcome and eager to hear from today's speakers, Dr. Sachin Nikate, Dr. Pratibha Baldava, and Dr. Pradeep Suryavanshi. Today's panel moderator, Dr. Bimal Sahani sir, with panelists Dr. Prathna Shah, Dr. Vandana Gandhi, Dr. Ranjit K Kerser, Dr. Bharat Pawar, Dr. Sudesh Doshi, Dr. Praveen Shinde, Dr. Manish Rani. All the faculties will definitely blast the webinar and make it interesting. I take the privilege to introduce our today's guest of honor, Dr. Sneha Bhuyarmam. Dr. Sneha Surendra Bhuyar, MBBS MD FICOG FIC MSCH, MBBS MD both from BJ Medical College and Sassoon General Hospital, Pune. She is the Managing Director of Sukhakarta Hospital Maternity Surgical Nursing Home, Laparoscopic and Infertility Center, Yavatmal, with 29 years of experience in this field. Her teaching experience is of 5 years at VNGMC, Yavatmal. She has been awarded National Individual Award by Foxy in 2008, Dr. Anandi Joshi Award by Government of Maharashtra 2005, Foxy President Appreciation Award for Public Awareness in 2018, Foxy President Appreciation Award for the Exemplary Work in Cancer Wow 2019, Champion of Foxy 2019, International MS Signature Award for Phenomenal Leadership 2020, Lokmat Healthcare Excellence Award 2020, Asia GCC for Leadership in Healthcare in 2021, Champion of Foxy 2021, National Expert UNICEF, Lead Assessor Foxy Manyata. He is a lead assessor for Foxy Manyata certification for the hospital. She has held official posts in Foxy as a Foxy chairperson for Breast Committee in 2019-21, Governing Council member ICOG in 2021-22. She was the founder president of Vidarbha Isoprop in 2017-2019, president of Yavatmal Obs Gynec Society in 2007-2008. She was the founder clinical secretary of Yavatmal Obs Gynec Society 2003, executive committee member of AMOX 2020-22. She is the organizing chair. She was the organizing chairperson for
Thank you so much. Thank you, Dr. Priya. Thank you for your wonderful, kind, and generous introduction. मी आपली महाराष्ट्राचीच आहे. सगळी लोक मला आपली खूप जवळची आणि ओळखतातच. थोडक्यात माझा परिचय, इनफॅक्ट मी आपणा सर्वांचीच आहे, एवढंच आहे. यू कॅन स्टॉप शेअरिंग.
ओके मॅम. Manisha.
Ranjit, you have to stop share.
Yes, yes, yes.
Over to you, ma'am.
First of all, thank you so much, Dr. Anjali Jamma and Dr. Priya Kadam for inviting me here and the entire organizing team. A very good evening to all of you. सर्वांना अकलूजकरांना माझ्याकडून शुभेच्छा आणि पर्सनली वैयक्तिकरित्या तुम्हाला जरी ऑनलाईन भेटते तरी अगदी खूप जवळच्या आपल्या लोकांना भेटते असं वाटते. खूप सगळी लोक तुमच्यातली स्पीकर चेअरपर्सन्स चांगली ओळखीचे आहेत आणि आय जस्ट टेक दिस अपॉर्च्युनिटी टू थँक ऑल ऑफ यू फॉर हॅव्हिंग मी हिअर अँड हार्टी congratulations to the entire team for organizing such a wonderful topic on the much needed topic. I would just say that fetal growth restriction, intrauterine growth restrictions, small for gestational age babies, low birth weight babies, whether physiological, constitutional, or whether pathological, such a topic of controversies where there is absolutely no consensus as far as the terminology is concerned, the etiology is concerned, the diagnosis and diagnostic tools are concerned, the surveillance, the guidelines for management and optimum timing as well as mode of delivery. Everything is in a mess. So much needs to be discussed, and I'm so happy to see Dr. Sachin Nichite, a fetal medicine expert here, who makes the subject very, very interesting. I'm sure, Sachin, you're going to rock this program. And of course, Dr. Pratibha Baldava, who is our own obstetrician, who's going to talk on optimum timing and mode of delivery. And I'm so happy to meet all the chairpersons, Dr. Anjali Jamma, Dr. Madan Kamre, and Dr. I'll just read out the names because I want to, say it out because as if I'm meeting you all personally. So I just utilize this opportunity to name all of you. Dr. Bimal Sahani, I can see as a moderator, and all the esteemed panelists for this program. So, of course, the chairperson, as I have already said, and panelist Prarthana Shah, Bharat Pawar, Sudesh Doshi. I can't see Dr. Sudesh Doshi here, but yes, he's there. Hello, Dr. Madan Kamre. Hello. Yeah, Dr. Vandana Gandhi. Hi, Vandana. So good to see you virtually. Very happy to meet all the old friends. Thank you so much having me here. And of course, you are having a very interesting panel discussion on the born too early or too late, and of course the management dilemma as far as the mode and timing of delivery is concerned. So very, very helpful topic. Which is need of the hour for the obstetric practice in day-to-day routine. So once again, hearty congratulations to all of you and all the very best to the program and to all your endeavors in the Foxy Society as a society to a closed society. So thank you so much. I think this was the area which in fact I have never had any programs virtually also. So special thanks to Dr. Anjali and Dr. Priya for that, having me here. Friends, this is not a time to make a vote appeal, but I belong to Maharashtra. Almost my schooling is from Jalgaon, my medical education entire from Vijay Medical College, Pune, and now I am based in Vidarbha, that is Nagpur region. So entire Maharashtra is ours, and I represent you all at AMOX and at FOXY level. So thank you so much once again for having me here. Thank you. Over to
Thank
you,
you.
Dr. Priya.
Thank you,
ma'am.
ma'am. Thank you for your kind words. We'll start our webinar. We'll start our first session, that is on fetal growth basic principles and Doppler in IUGR. For this, we have as a chairperson Dr. Anjali Jamma ma'am and speaker Dr. Sachin Nichite sir. Dr. Anjali Jamma ma'am, President Solapur Obstetric Gynec Society, consultant at Jamma Hospital Laparoscopic Surgery Center since 2000. It is the first laser gynecology center in Solapur and nearby districts. Special training in ultrasonography and laparoscopy, laser training in cosmetic gynecology, area of interest, cosmetic gynecology. Her present positions of office held are as the secretary in
Let it be.
2015-16. Over to you, ma'am.
Good evening, one and all. Thank you, Priya, Revati, and Aklus team for giving me this opportunity. And would like to congratulate for organizing such a wonderful webinar. Gone are the days when IUGR, oligohydramnios, IUDs, abnormal babies were acceptable in registered patients. But now in the era of fetal medicine, with the Brahmastra of EVSG in our hands, it is no less than a crime to miss these unforeseen mishaps. To update ourselves on the same, we are here. I take this opportunity to welcome our esteemed speaker, Dr. Sachin Nichite, who is famous for his unique oratory skills. He is consultant at three top fetal medicine centers at Vashi and Kharghar. He was invited as a faculty for many national and international conferences. He has worked as a member of Fetal Medicine Committee, FOXY and AMOX. He had authored 2 editions of a book, Passing DNB of St. Gynec and Rise of Superwoman. Over to you, sir.
Am I audible properly?
Yes, sir.
Yes, sir.
Okay. I am sharing my screen. I think madam has to stop sharing.
Yes, I'll do so.
Good evening, Aklu Society. Thank you so much, Sneha madam. It is always a pleasure to see you. Pleasant personality. Thank you, Bimal sir. Thank you, Priya madam, Manisha madam. Thank you, Anjali madam. Madan Kamble sir, the first person I know from Aklu Society. And thank you, Sudesh sir. Is my screen seen?
Yes, sir.
Okay. My presentation also seen?
Not yet.
Not yet.
Just a small announcement, sir, to all the delegates. They can ask question and answers and write in the question and answer box so that we can have that session at the end.
Seen now? Still not seen?
No, sir.
Screen is seen, sir, but not the presentation.
Not the presentation.
सचिन सर
Yes.
तुम्ही स्टॉप शेअरिंग करा एकदा आणि तुमचं जे प्रेझेंटेशन आहे ते ओपन करून मग परत स्क्रीन शेअर करा सर प्लीज.
Okay.
येस सर.
Sachin sir, please start your present. Open your PPT, then you can share. No,
Yeah, my PPT is open actually.
then
The screen only it is
just
open.
एकदम बरीच जण लावेत ना त्यामुळे
Still visible or not visible yet?
no, sir, it's not visible.
My screen it is open actually. Just a minute. Is it seen now? As a
No, sir.
no.
Sir, can you just send it in an email ID so that I can share it back end if you want?
No, that animations won't be seen actually properly.
Okay.
Okay, let me check again. Okay. I hope my screen is visible now.
No, sir. Screen is visible, sir.
Screen
Your
is visible.
screen is coming the presentation mode. The presentation is not visible, sir.
Okay. Okay. Is it seen now?
No,
sir.
Sachin,
Can you log sharing from your mobile or from the laptop?
सचिन सर
मी actually tab वर घेतलाय माझा laptop
तुम्ही
is
मोबाईल
not
स्क्रीन वर
working.
करताय ना सर
हाँ?
सचिन सर
बोला
तुम्ही
ना.
मोबाईल स्क्रीन वर करताय ना त्याच्यामुळे ते टॅब ओपन करावं लागेल सर तुम्हाला जे आपण क्लोज ऑल टॅब करतो ना आणि इकडे असं येतं याच्यामध्ये की युअर व्हिडिओ इज पॉज ड्युरिंग मोबाईल स्क्रीन शेअरिंग
अजूनही दिसत नाही का स्क्रीनवर माझा?
तुमचं सर होम स्क्रीन दिसतंय सर आता
ते मायक्रोसॉफ्ट फोल्डर आहे ना सर तिथं जाऊन वाटल्यास क्लिक.
एक मिनिट.
तो पर्टिक्युलर टॅब सर तुम्हाला ओपन करा आपण क्लोज ऑल टॅब करतो ना सर त्याच्यामध्ये जाऊन ओपन
आता दिसतंय?
करू शकता.
Is it seen now?
No, sir.
no,
Right?
no. Your video is paused during mobile screen sharing. असं येतंय तिथे.
ऍक्च्युली मी टॅब वरून चालू केलंय.
तर लॉग आउट करून लॉग इन करा परत.
अच्छा मी लॉग आउट होऊन एकदा परत लॉग इन करतो.
Sachin, log out and log in again. Try once.
Yes sir. Yes sir.
Yeah.
Seen? Not seen?
Screen seen, sir, but not the presentation yet.
Sorry for the delay. Actually मलाही कळत नाही टॅब वरून का ऑन होत नाही. पण मला स्क्रीनवर दिसतंय.
सर आयपॅड आहे तुमचा?
हा टॅब वरून
Okay, email ID I'm giving. You can just send it across. Then I can just share the slides. Then
I'm sending also, but the screen जे पुढे पुढे जायचं ना, that has to be in my hand actually. That is the problem.
Video pause during
You stop share it, sir.
mobile screen sharing.
Shall I send you? Give me email ID.
Sir, can I just spell it out? Can you write instead? RANJIT.
RANJIT.
Dot. SAHOO.
HOO.
SAHOO @walterbushnell.com. WALTER.
Walter WALTER
BUSH
BUSH
NELL .com.
Send.
Okay, I'll just check. My email ID is on, sir. Yet to receive, sir. It is you have sent it in Ranjit.sahu, no? SAHOO.
Yeah.
RANJIT.SAHOO@Walter Bushnell WALTERBUSHNELL.com.
Yeah. Send on the same email.
रंजीत सर रिसीव हुआ?
नहीं वही देख रहा हूँ ऑलरेडी, मैं वही चेक कर रहा हूँ, नहीं आया, इसीलिए मैंने सर से कंफर्म किया।
सर चैट बॉक्स पे और एक मेल आईडी लिखा है सर मैंने अभी,
वहाँ पे आप नहीं तो
अच्छा एक मुझे 2 मिनट दीजिए, मैं लॉग आउट करता हूँ फिर से लॉग इन करता हूँ। 1-2 मिनट दीजिए मुझे बस।
ठीक है सर।
Can we take the second talk by the time, Manisha?
We have to ask Sachin Nichete sir and Jamma ma'am. Is it okay, ma'am? Hello?
Hello, actually, what is the issue, Manisha? He can share the screen, no?
Nichete sir's PPT is not opening. Jamma ma'am, can we start with the second lecture?
I think we should, yeah. In the time we figure out, we can start with the second session and then we can come back to session 1.
Yes, just a minute, but let me ask the chairperson. Hello?
No problem.
No problem, no, ma'am?
Yeah.
Okay. So we start with the second session.
No.
It's okay, Sachin sir?
Yeah, please start, yes.
Yeah.
So now your screen is seen.
It's not sir screen, I think.
But on your screen, your video is paused during mobile screen sharing. It's constantly coming whenever your screen comes.
Okay.
But PPT not seen yet.
Yeah, not seen yet.
Okay.
So then we'll proceed with Dr. Pratibha.
Yeah, please. By the time I'll sort out what is the problem.
So
Yes,
for the second session, I call on Dr. Mansi Devdikar to conduct the second session. Mansi, are you there? Dr. Mansi? Okay, I'll start. Sachin sir, please stop sharing the screen. So we'll start with the second session, that is timing on delivery in IUGR. For this session, we have chairperson Dr. Madan Kamble sir and the speaker Dr. Pratibha Valdava ma'am. Dr. Madan Kamble sir. He has been he had been the chairperson at AMOX Aesthetic and Sexual Medicine Committee in 2022-24. Past president Akul's Obstetric Gynec Society, that is of the year 2021-22. Honorary Secretary Akul's Obstetric Gynec Society 2019-20. Member of Foxy Sexual Medicine Committee. Member of Council of Sexual Education and Parenthood International. Organizing chairperson of AMOX Zonal Conference on Sexual Medicine at Akulus in December 2021. He has done training in aesthetic gynecology by Laser and Health Academy, Slovenia, and has been faculty at AMOX and AICUG conferences. Over to you, sir. Over to Dr. Madan Kamble, sir.
Thank you, Dr. Manisha. Yeah. I would like to introduce Dr. Pratibha Baldava, madam. She is MBBS with distinction in obstetrics and gynecology from esteemed KEM Hospital, Mumbai in 2001. She has completed MD, DNB, DGO, FCPS, DFP with gold medal from KEM Hospital, Mumbai. She has done fellowship in infertility at late Dr. Mandakini IVF Center for 2 years up to 2009. She has taken laparoscopy training under Dr. Hafiz Rahman in 2010. She has done training in high-risk obstetrics, and she is assistant professor at Sooth Hospital and Trivandrum Medical College, Trivandrum in 2011. Yeah, I welcome Dr. Pratibha, madam, and over to you.
Thank you so much, sir, for that kind introduction. Should I start screen sharing?
Yes, ma'am.
Yes.
Just a minute, I'll stop my sharing.
Okay.
Over to you, ma'am.
Yeah. Start screen sharing. Yeah. Can you see my presentation?
Yes, ma'am.
Yes, yes, yes.
Okay, okay. So I'll just convert it to slideshow and you can start. Yeah. Thank you very much, Aklus Society, for inviting me here to speak on a topic which is actually a topic of dilemma. Everybody is in a state of confusion as to when to deliver an FGR baby. So let us understand first, what is FGR? FGR stands for fetal growth restriction. Intrauterine growth restriction is commonly defined as estimated fetal weight less than the 10th percentile of the fetal weight for that gestational age. Suppose if I'm seeing a baby at 28 weeks, if the expected weight of the baby at 28 weeks is somewhere around 1 to 1.2 kg, and if I see that this present baby's weight is falling less than the 10th percentile for that 28, then that baby becomes an FGR. While 70% of these are small for normal reasons and are not at risk, almost 30% are pathologically small. And these are the babies who are at risk of fetal death. What is more important and what are the difficulties that we face in managing FGR? Fetal growth restriction is challenging because of the difficulties in reaching a definitive diagnosis of the cause and then planning its management. FGR is associated not only with marked increase in the risk of perinatal morbidity and mortality, but also because of its long-term outcome risk. We need to combine fetal biometry, amniotic fluid volume, heart rate patterns, which we measure by ultrasound, doing the artery Dopplers, the venous Doppler, and which allow a comprehensive evaluation of this FGR. Am I audible?
Yes, ma'am.
Yes,
Yes, ma'am.
So, okay, should I go ahead?
Yeah, I request all participants to please mute their mics. Rest of the participants, please mute their mics.
Okay, so we would just go in short and see what are the causes of this FGR, and then we can exactly deal with its management. Usually, the cause for FGR are maternal causes, fetal causes, and placental causes. The maternal causes usually are the placental causes are the maximum cause for FGR, that is, which amount to around 30%. Constitutionally small babies around 22%, and chromosomal or genetic abnormalities result to around 20%. Whereas congenital infection like torch infections or viral infections, trisomies, this will result to around 5 to 3%. Twins are also known to have FGR, and when it is twinning, the management becomes totally different. So this is a normal growth baby. This is a symmetrically IUGR baby. And this is an asymmetrically IUGR baby. It is very important for us to understand the difference between symmetrical IUGR and asymmetrical IUGR. Symmetrical IUGR is when the head circumference and the abdominal circumference both are symmetrically small and falling less than the 3rd percentile for that gestational age. Whereas asymmetrical IUGR is when the head circumference or the head development, brain development is almost normal or more, and whereas the abdominal circumference is the one which is lagging. So symmetrical IUGR accounts for around 20 to 30% of IUGR cases. It is typically because of early onset IUGR that is less than 32 weeks. They have a normal ponderal index, which is a ratio of AC and HC. That is, they have both AC as well as HC is reduced. Therefore, the ponderal index comes to be normal. Example or causes for this early symmetrical IUGR is genetic disorders or torch infections. The Delphi criteria, which suggests the solitary factors to define symmetrical IUGR is when the abdominal circumference is less than 3rd percentile, the estimated fetal weight is less than 3rd percentile, and there is absent end diastolic umbilical artery blood flow. Whereas asymmetrical IUGR is responsible for around 70 to 80% of FGR cases. It is late in onset. It is seen after 32 weeks of gestation, and there is decreased ponderal index, means there is the head circumference is more compared to the AC. There will be increased HC to AC ratio. So there is decreased ponderal index. The most common for asymmetrical IUGR is PIH. Preeclamptic pregnancy-induced hypertension, malnutrition. The Delphi criteria is when the abdominal circumference is less than 3rd percentile or the estimated fetal weight is less than 3rd percentile. But it is the ponderal index which is the differentiating factor between the symmetrical IUGR and asymmetrical IUGR. Remember that the brain development is normal in asymmetrical IUGR, whereas it hampers or is decreased in symmetrical IUGR. This is again a very important slide which shows that the prevalence of symmetrical IUGR is less, 1 to 2%, whereas that of late onset IUGR is high. The problem in managing symmetrical IUGR is the management itself, whereas in late IUGR, it is the diagnosis which is difficult. We most of the times tend to miss it because if serial scans are not done at 5th month or 7th month and interval growth is not plotted or charted, we may easily miss a late onset IUGR. The placental disease has more severe intensity. In severe symmetrical IUGR, the umbilical artery Doppler is altered and it is highly associated with preeclampsia. Whereas in late onset IUGR, the placental disease is moderate, the umbilical artery may be normal, and there is low association with PIH. The extent of hypoxia is again severe in symmetrical IUGR, whereas it is less in asymmetrical IUGR. The cardiovascular adaptation of the fetus is systemic in symmetrical IUGR, whereas it is central in asymmetrical IUGR. A symmetrical IUGR baby is highly tolerant to hypoxia. It is so used to hypoxia because it is hypoxic since the early stages. So it becomes used to the hypoxia, whereas in late onset IUGR, the tolerance to hypoxia is less, and therefore there is more risk of stillbirth because this baby is not tolerant to hypoxia. So even if there is little hypoxia in later stages, it may succumb to it, and there is more risk of IUFD or stillbirth in late onset hypoxia. So morbidity and mortality is again high with early onset IUGR, but fetal demise or stillbirth is more with late onset. So this is again showing the difference between early and late onset IUGR. So what are the causes for this? Causes, as I said, are maternal, fetal, and placental. Maternal causes are usually uterine malformations, malnutrition, thrombophilia. Fetal causes are twin-to-twin transfusion syndrome, multiple gestation, trisomies, or viral infections. We need to know the causes in order to treat it. That is why we are looking into this. Placental or umbilical causes like chronic abruption, placenta previa, abnormal cord insertion, or cord abnormalities. FGR is also seen in twins. Twins are usually smaller than the normal, but FGR affects around 25% of twin pregnancy as well. This happens because if they are sharing a common placenta, then there will be a selective intrauterine growth restriction. If there is twin-to-twin transfusion syndrome, then there will be FGR, or if there are monoamniotic twins and the umbilical cord is entangled or so leading to less blood supply to one of the twins, then again there can be FGR. This is again a slide which is showing what are the causes for symmetrical IUGR. Symmetrical IUGR, as I said, is early in onset where the harmful factors are acting at the level of the zygote or early in pregnancy before 32 weeks. Most commonly, it is because of chromosomal abnormalities, intrauterine infection, or viral infections, trisomies. Whereas asymmetrical IUGR is mainly because of low placental function, late in onset after 32 weeks because of PIH, GDM. Chronic GDM can again lead to decrease in blood supply to the placenta and decrease in blood supply to the fetus, leading to IUGR or placental lesions. So why should we be worried if there is FGR? Because FGR may lead to premature birth and low birth weight of the babies. Because of there is FGR, severe oligomnias, associated Doppler changes, we might have to deliver the baby early, and which will lead to a premature birth and low birth weight. There will be trouble handling the stresses of the vaginal delivery because these babies, as I said, asymmetrical IUGR babies can succumb to hypoxia and can lead to fresh stillbirth even during vaginal deliveries. Hypoglycemia, that is low blood sugar level, low resistance to infection, so they are highly susceptible to sepsis. They can have low Apgar scores. There can be meconium aspiration, which can lead to respiratory distress. Hypothermia, unusually high blood cell count. There also severe FGR can lead to stillbirth, and it also leads to long-term growth problems. We cannot always prevent FGR, but a healthy lifestyle can go a long way towards lowering its risk. So now what are the tools? We have understood what is FGR when it is less than 10 percentile birth weight for that gestational age. What are the types of FGR? Asymmetrical and symmetrical. What are the causes of FGR? And so now let us see how to detect or diagnose FGR. A very simple tool is doing a symphysis fundal height. One of the simplest, commonest tool that which can use in our OPD on daily basis. When the patient comes, we make a column in our antenatal chart, record the symphysis fundal height. After 20 weeks of pregnancy, the measurement from the pubic symphysis up to the umbilicus is measured, or up to the fundus, uterine fundus is measured. That measured in centimeters should correspond to the number of weeks of pregnancy. So if she's come to us at 18 weeks, the symphysis fundal height should be 18 centimeters. If she has come to us at around 24 weeks, it should be 24 centimeters. That is how we chart it. The other very important tool nowadays is ultrasound, about which I think Nishitish sir is a better judge to speak on. I will just be touching on the superficially on it. On ultrasound, we measure the umbilical artery flows, the middle cerebral artery flows, the uterine artery flows, and we have to keep a check on the maternal weight. We need to record the maternal weight at each prenatal checkup. If mother's weight is not gaining, it could indicate a problem with the growth of the baby. So, role of ultrasound Dopplers. Umbilical artery Doppler measurement, when there is absent end diastolic velocity or reverse end diastolic velocity in the umbilical artery, it is a sign of danger. We need to keep a watch on that baby more closely, need to do repeated Dopplers, need to see its blood supply. it can corroborate to the diagnosis of FGR. If we want to know a single measurement that can tell us about the status of the baby, it is the MCA PSV, that is middle cerebral artery peak systolic velocity. It is a better predictor of FGR, which is associated, which can tell us about the associated perinatal mortality. So, all the literature that I have gone through, it says that no evidence supports that the use of cardiotopography or biophysical profile improves perinatal outcome. So obstetricians aim to identify fetuses with early FGR in order to plan the delivery according to the gestational age and the severity of the condition. We need to have, mind you, we need to have a very good neonatologist in the background who can take care of these FGR babies after they are delivered. So this is how we chart according to the weeks of gestation. This is the, on x-axis we put the gestational age, and on y-axis we put the weight. This is, when it falls in this range, it will be appropriate for gestational age, and when it is below this line, it will go in as FGR, and above this line will be LGA babies or large for gestation age. So when there is growth restriction, there are some chronic markers and there are some acute markers. Chronic or diagnostic markers is, we are looking at the uterine artery Doppler, the cerebroplacental ratio, the umbilical artery Doppler, and the middle cerebral artery Doppler. And there are some acute or prognostic markers which show that there is advanced hypoxia or acidosis and there is serious injury or it can lead to fetal death. These are the ductus venosus Doppler, or when we do a CTG, which shows severe decelerations or fetal decrease in the fetal heart rate. Once the FGR has been detected, we need to have a surveillance plan. Our plan should be such that we maximize the gestational age and deliver the most mature fetus in the best physiological condition while minimizing the risk to the neonatal, while minimizing the risk to the baby and minimizing the risk to the mother. So always we are in a dilemma that if I deliver this baby at 32 weeks, will the risk of prematurity will be more than keeping it in utero and having the risk of an intrauterine fetal demise. So our judgment is always, should be a risk-benefit ratio should be judged for both the mother and the baby, and risk-benefit ratio should be judged that the risk of prematurity should not be more than the risk of having an intrauterine fetal demise. While we are monitoring the baby in utero, the intrauterine treatment that we can give the baby is to improve the uteroplacental plateau. We can give supplements like zinc, iron, lycopene, vitamin E, folic acid, amino acid compounds. IV amino can be given to increase the amniotic fluid around the baby. Oral low-dose ecosprin in the dose of 75 milligram or 150 milligram. Nowadays, recommended is 150 milligram, which inhibits the synthesis of thromboxane A2 and increases the blood supply of the baby, can be given while we are closely monitoring these FGR babies. Also suggested is the use of low molecular weight heparin and low molecular dose aspirin, which will improve the outcome of FGR. But yet, there is no clinically proven trials. We need more trials to prove this. And we need to use drugs like betnesol or dexamethasone to improve or promote fetal lung maturity while we are monitoring and waiting to deliver these babies. Another important thing is if we are seeing that there is severe congenital malformations or severe chromosomal abnormalities, which has caused this early onset IUGR, then we might as well think of early termination of these pregnancies rather than taking a decision at a later stage where it will be more calamity, where it will be more of a calamity to the mother and the fetus. When the placental function is poor, but that if we find that the treatment can be effective, then and only then we should go ahead with expectant management. So then how do we do expectant management in these babies? What we can do is we can do, after we detect that after we have plotted the estimated fetal weight and we find that the estimated fetal weight is either static or is falling, then we can start intensive monitoring with the help of a weekly non-stress test, amniotic fluid volume determination, biophysical profiles, Doppler assessments, and if there is severe IUGR before 32 weeks, it is a poor prognosis and therefore therapy must be highly individualized. The reduction of placental supply of nutrients to the fetus is associated with severe adaptive changes which take place in both the placenta and the fetus, and this can lead to fetal death, and therefore staging of the disease is fundamental to time the delivery. Marked differences are observed in transplacental glucose gradient in most severe, and placental transport of amino acids is reduced in both in vivo and in vitro, and therefore it suggests that there is a problem with the placental metabolism and transport in FGR. So how do we time the delivery in case of late or early IUGR? In this case, we need to think of multiple factors like the degree of growth restriction, the etiology for the FGR, the amniotic fluid volume, the biophysical profile of the baby, and Doppler testing. But according to a very famous study, which has been quoted in Semen Parental in 2011 by Henry Gallen, it says that delivery should occur by around 37 to 38 weeks for singleton FGR babies. But if they are twins, and if there is a co-twin with IUGR, or there is chorionicity, monochorionicity, which is impacting the time of delivery, then delivery should occur as early as 34 to 36 weeks. But mind you, when we are delivering these babies early, a shot of corticosteroids or betnisol or dexamethasone to assure lung maturity is always assured or beneficial. Strategies involving expectant management has shown that it has resulted in stillbirth, spontaneous delivery, and induction of labor for uterine artery Doppler absent or reversed end-stage flow should also has short and long-term neonatal morbidity and mortality. So it is said that expectant management should not be followed in FGR babies, and early delivery becomes optimal when we are seeing that babies are FGR. There's again a study which I quote from Journal of Maternal Fetal Neonatal Medicine by Riley et al., which says that if there is IUGR, they prefer to deliver by around 36 weeks, whereas if there is again a risk of absent or reversal of end-diastolic flow, they may deliver as early as 35 weeks. Weighing the risk of iatrogenic prematurity against the poor outcomes associated with absent or reverse end-diastolic flow, it is better to deliver late preterm IUGR babies with elevated uterine artery Doppler indices as early as 35 weeks. So this is a chart which is showing that if the estimated fetal weight is somewhere around between 5th to the 10th percentile, but there is a normal uterine artery Doppler flow, I would wait. I would follow up this baby with a 3-weekly estimated fetal weight and an umbilical artery Doppler. If both of them are normal, then I will normally wait and deliver this baby at around 39 weeks. But if the estimated fetal weight is static, and there is a normal umbilical artery Doppler, then we repeat the umbilical artery Doppler at 3-weekly growth. If it is still normal, then we can deliver at 36 weeks. But if it is abnormal, then we need to immediately admit that baby and refer to a fetal medicine unit and deliver this baby at the earliest. If the estimated fetal weight is between 10th percentile, and if it is around less than 28 weeks, we need to immediately refer to a fetal medicine unit and need to take early or immediate intervention. If it is between 28 to 36 weeks, we can wait, do a 2-weekly estimated fetal weight monitoring, umbilical artery Dopplers. If it is showing a normal growth pattern, we wait and deliver at 37 to 38 weeks. But if it is static, with a static fetal weight that is not increasing fetal weight with a normal umbilical artery Doppler, we need to repeat the Dopplers weekly. And if it becomes abnormal, again, deliver immediately. But if the umbilical artery Doppler remains normal, we can wait and again deliver up to 36 weeks. If on doing the 2-weekly Dopplers, we find that there are both abnormal static growth and abnormal umbilical artery Dopplers, again, we need immediate intervention and need to deliver the baby. If there is absent diastolic flow, these babies, if they are less than 34 weeks, we need to, if they are less than 30, we need to deliver these babies. So slow, what do you mean by slow or static growth? Slow to static growth is defined as less than 200 grams of change over the 2 weeks. That is less than 140 grams of weight gain over per week, or 20 grams per day from 34 weeks. It should be induced no later than 37 weeks. If the estimated fetal weight is less than 10th centile at more than 36 weeks, then arrange delivery at around 39 weeks. Again, I quote a study which decides about the timing of delivery in pregnancies which are complicated by suspected fetal growth restriction without Doppler abnormalities. This study aimed to identify the optimal gestational age for delivery of pregnancies complicating growth restriction without Doppler abnormalities. In this, the cases of FGR without fetal Doppler abnormalities were identified from an ultrasound base. The primary outcome was a composite of perinatal morbidity and mortality. The risk of the primary outcome for each gestational age was compared with pregnancies delivered at 39 weeks and 40 weeks. It was found that among pregnancies complicated by suspected FGR without Doppler abnormalities, delivery at 39 weeks was safe with no difference in perinatal outcomes from 37 to 42 weeks. Thus, if there is FGR without Doppler abnormalities, we can safely wait up to 39 weeks. And there was found there was no perinatal outcome difference if we had delivered if these babies deliver spontaneously at 37 weeks or up to 42 weeks. So thus, again, I would like to summarize that if there is FGR between 28 to 32 weeks, we do a diastolic flow monitoring. Diastolic flow is present but decreased, then we can wait for outpatient management and do repeat a 2-weekly biophysical profile and Doppler. But if the Doppler is absent or reversed, we need to urgently admit the patient, give steroids, do a daily NST, do a daily Doppler, and deliver when the ductus venosus is abnormal. You remember when I showed that there is the slide where there's chronic markers and acute markers. So ductus venosus, if there is abnormal, it is an acute marker. It's showing that it needs urgent management. So if there is if the fetus is between 32 to 34 weeks, again the diastolic flow is present but decreased, we will wait, do twice weekly modified biophysical profile, Doppler, and 2-weekly growth scans, and deliver the baby at 37 weeks or earlier if there is no interval growth or abnormal BPS or absent or reversed end diastolic flow on umbilical artery Doppler. But if there is absent or reversed end diastolic flow, we again need to urgently admit this patient, give steroids, and deliver her. If she is between 34 to 37 weeks, again the same criteria follows. If there is absent or reversal, immediately deliver. But if there is diastolic flow present but it is decreased, we need to monitor and deliver again at 37 weeks. Then how do you deliver? Suppose that we are finding that there is abnormal ductus venosus or there is absent or reversal in the umbilical artery. Then we need to urgently deliver this patient by a cesarean section. But if there is FGR plus oligoamnios, but the Doppler findings are normal, or there is FGR, blood elevated umbilical artery Doppler, but there's a normal AFI, then we can induce labor. Nowadays, we do it in misoprostol. This paper was long ago in 2017 by CNC Vellore, and they used Foley's catheter and they attempted vaginal birth. But if there is severe FGR and obstetrician decision and monitoring are available, then we can do vaginal delivery in an appropriate setup. But if facilities for monitoring are not available, they have advised that we immediately deliver the baby by LSCS. This paper was based on RCOG recommendations, and this is a very good paper which I went through, and it gives us the treatment protocols in Indian scenario, and it is based on RCOG recommendations. So I would highly recommend that we follow this in our practice, day-to-day practice. So thus our vision is to deliver more healthy babies to give more babies the best possible opportunity to achieve their full health and full life potential. Thank you.
Thank you, ma'am.
Yes.
Dr. Madan sir, can
Yes.
you add some words?
Yeah, thank you, Dr. Pratibha madam, for a wonderful talk.
So thank you so much.
Yeah, very well explained the difficulties and management of fetal growth restricted babies, causes and consequences. You have also very well focused on role of color Doppler and various markers. You have very well focused on the intrauterine treatment, that is intensive care of baby. You have all highlighted the management of appropriate timing of delivery and antenatal fetal monitoring. We all know the competent neonatologist and tertiary NICU facility should be available. Shall we take questions? There are 2 questions.
We are going to ask question answer at the end.
Okay, it's okay.
You
Yeah,
can.
Thank you very much, sir. Thank you very much, Priya madam. Thank you, Vandana Gandhi madam, for giving.
Thank you, ma'am.
Yeah, thank you.
It was nice.
Thank you, ma'am. Very nice lecture. Very nice.
Thank you so much. Thank you so much.
Thank you, ma'am. Will you stop sharing, ma'am, please?
Yes. I will stop sharing. Yes.
Manisha madam, should I share the slide of Dr. Sachin sir?
Just
a minute. I'm trying once.
Yeah, just a minute. Dr. Pratibha Baldwin, ma'am, to accept this trophy as just a token of love from Accru's Obstetric and Gynec Society.
Thank you so much. Thank you so much.
Yeah, and also our chairperson and our own past president, Dr. Madan Kamesar, please accept this trophy as token of love from Accru's Obstetric and Gynec Society.
Thank you, received.
Thank you. Yeah. So over to now, Dr. Sachin Nitede, sir. I'll stop my
I
sharing.
hope I'm able to share now.
All the best, Dr. Sachin.
Thank you, sir. Please stop sharing.
Done, sir.
Done. Why just pause? Screen seen or not seen?
No, it is same message is coming, sir.
Anybody from Walter and Bhushner can help, no?
Yeah, please project the screen.
I am projecting.
सचिन सर तुम्ही मेल केलाय का?
Yes,
हो,
yes,
मेल
done.
केलाय मी तुमच्या मेलवर.
कोणाच्या मेलवर केला? रणजित सरांच्या?
नाही, आता जो तुम्ही पाठवला होता ना WhatsApp.
Just sir, विशाल sir करतात.
Now you
Yeah,
start.
Dr. Vishal Mahane sir is chairing. You can start, sir.
Yeah.
Okay.
Yes, sir. Please, sir.
Am I audible properly?
Yes.
Yes,
Sure,
sir.
sir. Yes, sir.
Okay, let's start. Go ahead. So we are to discuss about growth restriction. Okay. Previously it was called as IUGR, fetal growth restriction. Next slide. Yes. So there is a lot of debate about what is growth restriction, what is growth retardation. I think it is a unanimous decision that we should call it more like a FGR. It looks more human, not like a retarded thing. Now this growth restriction is a very naughty thing, very dangerous thing. मतलब जब से सिम्फाइजियो फंडल हाइट मेजर कर रहे हैं सब लोग, तब से लोगों को पता है कि फीटसेस कैन बी स्मॉल, बट तब से ये IUGR या FGR की गुत्थी किसी से सुलझी नहीं है. It is such a complex topic. After so many decades also we are discussing when to deliver, how to deliver, because this is very complex topic and बहुत बदनाम topic है ये. Whatever happens to the fetus which is not known, on paper it is written as undiagnosed FGR. So what is attributed? Can you click the next slide? Go on clicking. Okay. Stillbirth, fetal distress, cerebral palsies, long-term neurodevelopmental delay, doctor's distress. So many distresses are related to this growth restriction. Go on clicking. Adulthood diabetes mellitus. Next. Go. This trouble will come now. Okay. Fine. Stop now. Now the trouble with fetal growth restriction is why it is so much unsolved problems in so many decades. That it is a classic case of management variability. You know what is management variability? अगर किसी को फीवर आया है, somebody gives an injection, somebody gives a tablet, और कोई किसी reason के लिए surgery plan करता है. That is called as management variability. The same thing is happening with fetal growth restriction. Everybody applies its own brain. मुझे जैसा लगता है वैसे मैं ग्रोथ रिस्ट्रिक्शन मॉनिटर करता हूँ. मुझे जैसा लगता है अभी डिलीवर करना चाहिए, शायद मैं डिलीवर करता हूँ. That is the problem with fetal growth restriction. So what we will do in this PowerPoint presentation is, I want to make it simple. Okay, I want to make it digestible, that आपको पचेगा. Plus, I want to give you some things which you can apply right away in your practice. And third, we'll try to make it objective. You know what is objective? Management of fetal growth restriction so far is very subjective. You know, we will make it like a guideline. Okay, we'll go step by step, so that you will apply this in your own clinical practice. Next slide, please. 3 clicks, bus. So what are the 3 questions we ask frequently? You know, क्या देख के छोटा बोला फीटस को? कितना देखा, कुछ क्वांटिफाई किया तो छोटा बोला है क्या? एंड अगर तुमने छोटा बोला है तो क्या नॉर्मल वाला छोटा है या प्रॉब्लम वाला छोटा है? These are the 3 basic questions each obstetrician, each ultrasonologist ask themselves. So हमें इन बेसिक 3 क्वेश्चन का आंसर अगर मिल जाता है, so we are up to the diagnosis of fetal growth restriction. Okay. Next slide, please. Click. Yes. क्या देख के छोटा बोला? Fetus में मैंने क्या देखा? So I have labeled it as a small fetus. First question is very important. The first step क्या देख के छोटा बोला is, I should have a correct gestation age in my hand. That is the most and first important step. If you are wrong about your gestation age, you cannot diagnose fetal growth restriction. Because of this, a simplest small step, there are so many errors which are created for this. Second step is, I have identified my gestation age. Now, accurate measurement. Now, the sonologist, or if I am doing a scan, I should be able to quantify with ideal planes, ideal guidelines, so that my measurement is near to ideal. That is accurate measurement. And क्या देख के छोटा बोला? So only 2 parameters. Don't include anything else in your clinical practice. Include AC and estimated fetal weight. So मैंने क्या देख के छोटा बोला? I have a correct gestation age, I have measured correctly, and then I have seen AC और weight कहाँ पर है, then मैंने इसको छोटा बोला. Next slide, please. Sir, see, this is my growth geet. I always tell this. 3 clicks, please. बिना असाइन किए ईडीडी काम नहीं करता. एक बार असाइन करके कमिटमेंट कर ली तो मैं खुद की भी नहीं सुनता. गिनना एक एक पैरामीटर सही जगह पे जूम करके और रखना कैलिपर ध्यान से. ग्रोथ कर्व्स पे प्लॉट जरूर करना भैया, और फिर ही कहना एसजे शान से. These few lines explains everything about fetal growth restrictions. We'll go ahead. I will emphasize a lot on gestation age assignment also. Next slide, please. Yes, the first step I have to see कि मेरा fetus कितना gestation age का है. This is the first step for a sonologist, first step for ultrasound person, for an obstetrician. So I give you 5 simple rules to decide the estimated expected date of delivery or the correct gestation age. Next slide, please. The first rule is assignment of EDD. Click, please. Yes. Click 3 times. One more time. Yes. The best time to assign a gestation age is 10 to 13 plus 6 weeks, or that is 32 to 80 millimeters of CRL. This is the best time. अगर किसी ने अच्छा CRL लिया है, what are the criteria we see? There should be a mid-sagittal fetus, horizontally oriented. It should fill almost 75% of the screen, and fetus in the neutral position. Matlab, there has to be a lighter pocket between chin and the thorax. The end points, the red plus I have seen, the end point should be seen clearly. So I can measure it properly. So this is the best time to assign gestation age by CRL. LMP is not बहुत reliable है ही नहीं. No, even if patient is so sure about it, unless and until it is an artificial reproductive technique, fetus, तब तक LMP is not sure at all. Next slide, please. Yes. Second rule. If अगर sonologist को ऐसी CRL नहीं मिली है, या he is not able to take it, या अगर आपके sonology की रिपोर्ट में ऐसा नहीं दिखा है, then the next rule is कि 10 to 50-13 का CRL नहीं मिला है, तो around 8 weeks का CRL, but it should be more than 8 weeks, not less than 8 weeks. 8 weeks से छोटा fetus बहुत छोटा होता है. The caliper placement is not that accurate. So अगर first thing मुझे NT scan में अच्छा CRL नहीं मिला है, तो 8 weeks से ज्यादा का fetus का CRL is the second ideal thing. Third, next slide please. बस. Rule 3 is if the patient has not come to me prior to 14 weeks, वो आया ही नहीं है, उसके पास अच्छा scan नहीं है, किसी ने handwritten scan लिखा हुआ है, so I will decide the gestation by head circumference or femur length, provided both parameters are equal to each other. Fourth rule, अगर patient मेरे पास 24 weeks के बाद आया है, please don't assign gestation age. It is not the time to assign the gestation age. It is the time to assess the size only, that is the weight. फिर आप पूछेंगे इसका gestation कैसे decide करेंगे? It is decided by the interval growth. I will call the patient after 3 to 4 weeks. If it is fulfilling the interval criteria properly, then probably the last period date is the correct date. Last and fifth rule is please don't change gestation age once it is assigned. Next slide, please. This is very important. Once I have assigned gestation age, आपने कई सारे reports देखे होंगे radiologist के. एक स्कैन में एक ईडीडी, सेकंड स्कैन में दूसरा ईडीडी, थर्ड स्कैन में दूसरा ईडीडी. बर्थ डेट चेंज नहीं होती है, तो देयर कैन बी माय हाइट विल चेंज ग्रेजुअली, बट माय बर्थ डेट विल नॉट चेंज. द सेम वे fetus का estimated fetal expected delivery
Hello,
Hello.
ma'am. I think there is some network issue.
Network issue. Yeah.
Hello.
Hello. I will call, sir.
Yes, ma'am.
There is a lot of trouble today. Yeah, I'm moving my hand. So rule number 5 is please don't change gestation age once assigned. Next slide, please. So what we have done is we have determined the gestation age. If it is a ART pregnancy, it is very simple. We use formulas, but for you, if it is a fresh IVF, then egg retrieval rate minus 14 is the correct LMP. Or if it is a frozen IVF, then the embryo transfer date is the correct date. Okay, that is the date of conception. Next slide, please. Yes, if it is a twin dating, okay, so go on clicking, go on click. Bus. If it is a twin gestation, again the 11 to 14 weeks is the correct time to assign the gestation age. The CRL criteria remain the same. One important point to remember is the CRL of the larger fetus has to be included in gestation age assignment. If it is IVF pregnancy, then ET and Onsite retrieval age is the final one. Please click. Okay, so now I have assigned the gestation age. Now how to measure it accurately? For जो भी स्कैन करने वाले लोग हैं जो ऑडियंस में है उनके लिए मैं थोड़ा कुछ देता हूँ इसमें. How to measure it accurately? I will go little faster. So this is little more in deep. So 3 principles of accurate measurement is zoomed in image. That is first thing. Click please. 3 clicks. Yes, at least 75% screen has to be occupied. Then correct planes, the knowledge of correct planes, the correct landmarks is important. And third is caliper has to be placed correctly. So I will go to planes of 3 sections very quickly. Next slide, please. Click. I will tell to stop. Yes. So this is the correct section of a BPD or head circumference. A cross section at the level of lateral ventricles or thalami. The midline, the falx has to be seen very clearly. The parietal bones are to be equidistant from the falx. A box-like structure that is called as cavum septum pallidum has to be seen. And the skull, the counter has to be regular. These parameters to be fulfilled for a correct BPD plane. Next slide. This is a femur length. The both end points of ossified metaphysis clearly visible. The epiphyseal spur should not be included in the measurement. The femur has to be aligned in the horizontal axis, not more than 15-degree axis. Therefore, not like hockey stick appearance. And the longest axis has to be measured. So I have correct BPD. I have calculated or measured BPD correctly. I have measured FL correctly. The last parameter is the most important. Next slide, please. AC. Yes. सबसे ज़्यादा mistake AC में किया जाता है. The circumference, the section has to be clearly circular. The short length of umbilical vein is to be seen. That typical curvature. That has to be seen in the section. No kidneys to be visible. Stomach has to be visible. Next. What is the mistake done is, if the long axis of umbilical vein is included, like in the upper picture, so AC will be abnormally high. So that is the biggest error. See, in estimation of fetal weight, AC has the most, the weightage of calculation is the AC. और उसी में अगर mistake हो जाएगा, the calculation is different. Your estimation of growth restriction will be different. So the section has to be at the short length of umbilical vein, not the long arm of umbilical vein. Next section. Next slide, please. Yes, it is calculated by 2 methods. One is by ellipse and by 2 diameters. Anyone is fine. Nothing, no more is, none of is superior to each other. I use ellipse. It is easier and more reproducible. Next slide. Next slide. Yes. Now what I have done is, I know the correct gestation of the fetus. Now I know I have measured the weight and AC of the fetus. अब उसको compare करना पड़ेगा. तो कैसे compare करने का? It has to be compared with a centile chart. What is a centile chart? See, that era has gone where the somnologist is to report by 2 weeks lag, 3 weeks lag. it is so subjective. You cannot define growth restriction by that. Nowadays, it has to be compared on a chart. 5th centile, 95th centile. You will say these charts are not available with us. ये हमारे पास है ही नहीं. No, each scan machine, there is a chart. So some of the obstetricians in Navi Mumbai, what they have done is they took the charts from me. They have printed the charts under their table and they compare the growth. That is very simple. So it has to be compared on a centile chart. So कितना देखा तो छोटा बोला. If the weight and AC less than 10 centile. Click please. Click. Click. Yes, if estimated fetal weight and AC less than 10 centile, then it is called as growth restriction. I will be revising each step again and again. मैंने gestation is correct किया. I have measured the parameters correctly. I have compared AC and weight on centile chart. If any one of them is less than 10 centile, it is a small fetus. Next slide, please. Yes. Now, many times what happens is only one plotting is does not satisfy our criteria. ना एक आदमी को अगर हम मिलते हैं कभी तो एक बार के उसके बिहेवियर से हम उसको नहीं जान सकते कि वो अच्छा आदमी कि बुरा आदमी. हमें उसको 2 बार 3 बार जानना पड़ता है. Then only हम डिसाइड करेंगे कि अगली बार भी वो ऐसा ही है क्या. Same for a fetal growth. Once we have plotted the growth, हम उसको normal level नहीं करेंगे. We have to follow that chart every 3 to 4 weeks. I call it as a मोक्ष का रास्ता. Next slide, please. Yes. Click. Yes, this is important. Now, so far, what we have done is we have identified a small fetus. Small fetus matlab AC and weight less than 10 centile is a small fetus. But it can be a normal small fetus. It can be abnormally small fetus. So, what is the answer to this question is, I have to interrogate the fetus by Doppler studies. Then only I will know whether it is a small for gestation fetus or a truly growth restricted fetus. Next slide, please. Yes. So how do I do that, and why it is so important? If I talk about a normally small fetus, what are the criteria? There are no signs of adaptation. It is a normal growing fetus. It has a good outcome, no risk of IUD. But as opposed to it, if it is a growth restricted fetus, truly growth restricted fetus, it will have signs of adaptations. It has perinatal outcome problems. It also has a risk of IUD. So management is totally different. So try to understand every small fetus is not growth restricted fetus. Don't try to deliver them prematurely because you feel it is a growth restriction. How do I do that? Click please. Yes, how do I differentiate? If weight is less than 10 centile, if any of these 3 criteria are fulfilled, I label it as growth restriction. What are those criteria? If uterine artery, mean uterine PI is more than 95th centile, if very low birth weight, if estimated fetal weight less than 3rd centile, or CP ratio less than 5th centile, I label it as growth restriction. I'm coming to it. What do I mean by CPR? If none of these 3 criteria are present, weight less than 10 centile, it is presently a small for gestation fetus. Next slide, please. What is cerebroplacental ratio? No. Previously, only umbilical artery is to be used for differentiating between growth restriction and small for gestation. Umbilical artery as a standalone is no more valid. Okay, so we have to use multiple parameters, multiple Doppler parameters for our assessment. Next slide, please. Yes, CP ratio is the ratio of MCA PI divided by umbilical PI. We use centile charts for assessment whether CP ratio is less or no. If CP ratio is less than 1, it is a less CP ratio. It is a clear-cut sign of some trouble to the fetus. There is some distress to the fetus inside. So this is one of the major criteria to differentiate between small for growth restriction fetus and a small for gestation is fetus and growth restriction fetus. Next slide, please. Next slide. Yes, identified a small fetus. I have removed SGF from FGR. Now my diagnosis is certain. I have diagnosed it as fetal growth restriction. Next slide, please. Yes, this is important. See, try to understand now. I have diagnosed it as fetal growth restriction. This is most important part of this presentation. No, I am going to give you something objective to act upon. So I will give you a stage-wise management and the timing of delivery. I might overlap with Dr. Pratibha's presentation a little bit, but I will try to simplify a bit. See, first part, everybody has to understand, and the patient has to be conveyed upon that fetal growth restriction cannot be treated. तुम कुछ भी दे दो, अमाइनो एसिड दे दो, तुम फ्लूइड्स दे दो, any medication दे दो, fetal growth restriction cannot be treated inside. First part. Second part is it is a problem of placenta. Placenta cannot be changed. Third part is the only treatment for fetal growth restriction is the correct time of delivery. Now, how we decide the correct time? You know, we have to weigh between iatrogenic preterm and minimizing fetal injury by acidosis. Why acidosis? थोड़ा हाथ से निकल गया होगा fetal growth restriction. तो हमें इसके बीच में weigh करना है. Next slide, please. So there is a fantastic classification by Gretakos. It will simplify your management protocols. Even if you're obstetrician, if you're a sonologist or obstetrician doing their own scans. How we decide the staging? Stage 1 is very low birth weight, less than third centile, CP ratio less, mean uterine PI increased, umbilical more than 95th centile, or MCA less than 5th centile. Majority of growth restrictions which you and we encounter land in stage 1 initially. This is mild placental insufficiency. Fetuses are better, they behave better. Stage 2, very important. Umbilical artery absent end diastolic flow or reversal of aortic isthmus. For obstetrician, just simply remember if it is absent end diastolic flow, fetus has gone to stage 2, which is severe insufficiency. Stage 3 is reversal of umbilical artery or ductus PI more than 95th centile. This stage we don't want preferably. This is a suspicion of acidosis. And stage 4 is DV reversal, abnormal CTG, FHR deceleration. हम लोग या आप जो भी सीनियर्स है, जो आप रेसिडेंसी में काम करते थे, maximum fetal distresses land into this stage 4. This is actually acidotic fetus. We don't want to reach to the stage. So what we have done is I have categorized the fetus according to the severity. Now how we deliver them? Next slide, please. If it is a stage 1 fetus, I will monitor the fetus weekly, provided there is no maternal factor. Maternal factor, gestation diabetes, hypertension or preeclampsia, or any other maternal disease like a connective tissue disorder. Provided these are not there, then I will monitor them weekly. I am aiming to deliver at 37 weeks. I have to convey to the patient why 37 weeks, because we are waiting inside. The fetus is already in distress. We are waiting only for the lung maturity. 37 weeks, it's fair enough. And in current era, 37 weeks, this is fantastic enough to deliver. Can be delivered by labor induction C-section, that is the obstetric indication. Next slide. Yes, stage 2, which is absent end diastolic flow, still we can wait. If it is less than 34 weeks fetus, I will do bi-weekly monitor. Every 2 to 3 days, I will monitor that this absent does not turn into reversal. I want to utilize this time for basically steroid action. So 34 weeks delivery I am aiming. Once 34 is reached, preferably to be delivered by C-section. Please मेरा नाम मत बताओ इंडिकेशन में, मैंने बोला था प्रेजेंटेशन में. Yes, these fetuses are little weaker to deliver by vaginal delivery. They may not withstand the contractions. So preferably for a better outcome to be delivered by C-section. Next slide, please. Yes, the third stage, which we don't want, is the reversal of umbilical. Only can we wait for steroid action if it is required, delivery by 30 weeks, and to be delivered by C-section. Last slide is the stage 4. Suppose we encounter anyhow, mostly it is delivered to be delivered soon, immediately. 26 weeks, anything beyond that to be delivered, provided your NICU backup is strong and the parents are counseled about it, about the consequences, about the expenses of NICU, and to be delivered by C-section. This must to be delivered by C-section. Next slide, please. Next. Yes, what we have done, we have identified small fetus by gestation is correct assessment. We have measured it correctly. We are compared with centile chart. We have identified a small fetus. We have removed small for gestation from growth restriction. If it is true growth restriction, I have done a multi-vessel Doppler, which includes umbilical artery, MCA, DV, and aortic isthmus. I have done a staging and I have delivered the fetus as per the stage. This is the crux of today's presentation. Next slide, please. Yes, a last slide, that is food for thought, late onset FGR. Dr. Pratibha has already brushed on the topic. Just a few points to it. Next slide, please. Yes, early onset FGR are the typical growth restrictions we encounter. They are a consequence of severe placental insufficiency, chronic hypoxia. They follow ekdam classic cascade. Uterine artery will increase, Iogr will decrease, umbilical increased, then MCA decreased, reversal, and absent diastole. The problem is management. Problem is not the diagnosis. They speak on their own. Okay. The problem of management we have discussed a bit by doing the stage-wise management. As opposed to them, late onset FGRs are a result of mild insufficiency. They follow erratic cascade. It's not sure that umbilical will be increased and absent, then only will deliver. Even mild hypoxia, these fetuses are very prone for intrapartum or even during late pregnancy mortality. The problem is the diagnosis. Next slide, please. Important is use the centile charts, and here the criteria may not be obvious for diagnosis, for late onset diagnosis. It may not be 10 centile AC and weight. It may be a slight decline in the growth. It may be a slight increasing mean uterine PI. You have to understand the concept of late onset FGR properly and don't miss them. That is the last part of the slide. Next. Yes, take home message, karma take home message. I have repeated this in my many presentations. जब भी हम कोई भी action लेते हैं, that action lands into 3 possibilities. Click. One possibility is 3 clicks, please. एक possibility है कि अगर कुछ काम मुझे कर्मा करना है, I just don't do it. एक होता है कि just do it somehow, मतलब कर दो बस. And last is do it to make a difference. For a growth restriction, this is very, very important. मैं ऑब्स्टेट्रिशियन हूँ, मैं सोनोलॉजिस्ट हूँ. मेरा काम इतना नहीं है कि मुझे पैसे भी सोनोग्राफी करनी है. मेरा काम ये नहीं है कि मुझे किसी से भी सोनोग्राफी करवानी है. मेरा काम ये नहीं है कि ग्रोथ रिस्ट्रिक्शन दिखा तो डिलीवर करना है. मेरा काम ये नहीं है कि हार्ट बीट प्रेजेंट वाला न्यूनेट निकाल के पीडियाट्रिशियन को दो. मेरा काम खत्म, मैं लीगली सेफ. द नेक्स्ट जनरेशन का आउटकम मेनी टाइम्स इज इन आवर हैंड. एटलीस्ट जो साइंस बैक्ड अप एक्शंस है उसको लेना हमारा रिस्पॉन्सिबिलिटी है. बाय डूइंग एक्शंस, व्हाट आर द एक्शंस? बाय correctly diagnosing growth restrictions, by correctly taking action on the growth restriction, correctly delivering them on the right time, preventing acidosis and mortality, maybe morbidity, we will make a difference in our practice. Thank you so much.
Thank you, sir. Thanks for the elaborate lecture. Over to you, Jamma ma'am, for the few words.
Thank you, sir, for wonderful talk. You have very well explained how to decide EDD, when to decide, and how to get a gestational age, proper gestational age, how to measure correctly, and explain well importance of CP ratio and Doppler studies. Thank you, sir. Thank you very much.
Thank
You
you
have
so
given
much.
very clear-cut ideas about the IUGR and Doppler. Thank you.
Thank you so much. Thank you.
Anybody is having questions?
We will have a question answer session at the end, please. Everyone are requested to write question and answers in the question and answer box. Sorry, questions in the question and answer box. This is small token of love from Agrus Obstetric Gynec Society, Dr. Sachin Nichetes, sir. Please accept
Thank you
it,
so
sir,
much.
as it is a webinar.
Thank you so much. Yeah, I received already.
Yeah. And to you, Jamma ma'am, as our chairperson, thank you for your valuable time.
Thank you. Thank you.
Yes. For the next session, which will be a panel discussion, I call on our Agrus Obstetric Gynec Society member, Dr. Kajal Kavitke, to head the session. Over to you, ma'am, Dr. Kajal Kavitke.
Hello, Manisha.
Yes,
Just
you're
check.
audible. Yeah, you're audible.
No, it's me. Actually, just check if Kajal can unmute herself or not. As she
I have
joined by
told
the
the water emotional persons also to unmute her, and
actually she has joined by the party.
Please unmute Dr. Kajal Kavitke.
Yeah, because Mansi couldn't speak. Just check whether, or I will call her and just check, because if she cannot unmute herself, she won't be able.
We've already told them.
Okay, let's wait.
Yes. I will once again remind them. Just a minute. Anyone from Water and Emotional, please unmute Dr. Kajal Kavitke.
Yeah, ma'am, Dr. Kajal has joined as a attendee. I have promoted her as a panelist.
Yeah.
Actually, yeah.
I have promoted her now as a panelist.
Yeah, now she can speak.
Yes,
Am
I audible now?
Yes,
now she's
audible.
available. She can just make her screen means on video on.
She is audible. Let her speak.
Right.
Yes.
Thank you, ma'am.
Good evening, all of you. I am Dr. Kajal Kavitke. I'm going to give introduction for the third session panelist and moderator. The panel discussion is on born too small, too early, management dilemma in preterm IUGR. Moderator for today's session is Dr. Bimal Sahani. Dr. Bimal Sahani is the director of Sonoscan Center, Aurangabad. He is the national president for Society of Fetal Medicine, and he is an academic coordinator, scholar, MD Fetal Medicine training program. He has done his MD radiology, and he is a co-author of the following publications: Second Trimester Guidelines of the Society of Fetal Medicine, principal author SFM oriented guidance statement for ultrasound establishments during the COVID-19 pandemic. He has given presentations. He has been a faculty at various national and international conferences, and his areas of interest are fetal growth and Doppler fetal echocardiography. Our panelists are, our first panelist is Dr. Prathana Shah Deshpande. She has done her MBBS TNB FFM, and she is a consultant of maternal fetal medicine at Cape Pond Hospital, Aurangabad, specialized in high-risk obstetrics and fetal medicine. She has a 10 years of experience in this field. She has also presented papers and posters in state and national conferences. She has worked at various prestigious institutes at Bangalore, Mumbai, and Pune. She is the first maternal fetal medicine consultant of Marathwada region, now working for more than 5 years in Aurangabad. She has successfully completed 500 fetal invasive procedures, including intrauterine fetal transfusions in Aurangabad. Our second panelist is Dr. Bharat Pawar, who is our own member, Akluz Obstetric Gynec Society. He is a consultant obstetrician, gynecologist, and sonologist at Anand Hospital, Maashiras. He has done his MBBS from BJMC Pune, DGO DFP from YCM Pune, and he is practicing since last 20 years in Maashiras, has a special interest in preventive obstetric sonography and infertility. Our third panelist is our esteemed Dr. Sudesh Doshi sir from Pandharpur. He has done his MBBS DGO and he is also a medical legal consultant for all of us. He has done his LLB. He is a senior obstetrician working since 25 years in a rural setup at Pandharpur. Experience of delivering over 12,000 babies at his nursing home. He is a chairperson, medical legal committee, AMOGS. He is a member of NIMC, FOXY, and he is a past president of Pandharpur Obstetric and Gynec Society. Our next panelist is Dr. Ranjit K Kerser. He has done his MD, DNP, UG and PG both from Dr. VMCC Solapur. He is a practicing gynecologist at Sangola since 2005. He has completed laparoscopy training with PG Paul Kochi. He has special interest in fetal first trimester anomaly scan and fetal echocardiography. He is he has done his interventional sonography and fetal Doppler in IUGR. Our next panelist is Dr. Vandana Gandhi Madam, our own founder of Akluz Obstetric Gynec Society. She has done her MD DGO, has done diploma in pelvic endoscopy. She is a consultant in obstetric gynecologist and sonologist and endoscopy surgeon. She is a founder of Female Fetus Protection and Safe Girls Counseling Center, Akluz. Founder of Akluz Obstetric Gynec Society 2004, President AOGS 2018-19. She has done a special activity under Safe Motherhood and Anemia Chale Jao program in 2004, and anemia prophylaxis model by her has been taken by Satara district role model under UNICEF support in 2006, which was implemented for 1.5 lakh schoolgirls. She has received many awards. Among them is Srimati Maharashtra 2001, Stree Bhushan Puraskar 2005 by Government of Maharashtra Health Ministry, Dr. Anandibai Joshi Gaurav Puraskar 2007, Ananya 2007 Women Achiever Award by Central Ministry. Our next panelist is Dr. Praveen Shinde sir. He is a consultant pediatrician and neonatologist practicing in Dr. Shinde Nursing Home and Ankur Critical Care, Akluz since last 12 years. He has done his MBBS from KIMS Karad, DCH from Mumbai, presently also working as ARCH coordinator at SDH Akluz. He is a master trainee of various RCH programs. Our next panelist is Dr. Manish Rani sir. Currently, he is a consultant at Apex Hospital. He has done his MBBS, DCH, DNB and fellowship in neonatology. He is author of Risk Factors of Febrile Seizures, Journal of Evolution of Medical and Dental Sciences, and his areas of interest is echocardiography. Over to you, ma'am, Manisha ma'am.
Yes, now
We call our moderator, Dr. Bimal Sahani, sir, to conduct the session. I'll stop my screen. Over to you, sir.
Good evening, everyone. And at the very onset, would like to thank the team from the Akluj OBGY Society for having me for this program. I think I'm the only odd man out here. Just in a group of esteemed obstetricians here. But when Dr. Gandhi spoke to me, and since the topic was FGR, I just couldn't say no, because that is a topic which is very, very close to my heart. And as you must have seen on my CV also, fetal echo and growth in Doppler. These are two topics which I really, would never miss out on an opportunity to speak or to listen to anyone. And we've had some wonderful lectures. I could attend part of both the talks, and our esteemed speakers have already taken us through some primary concepts, the literature, what is available, what is the evidence at the moment, what is staging. So we now move to panel discussion. The initial part of the panel discussion again is going to be a repeat of some of the things, but then we would listen from our esteemed panelists, what do they feel and how much they accept what is available in the literature. And then we will take you through some cases to primarily understand how we put all this into clinical practice. Now, I have a wonderful list of panelists here. Dr. Pratna Shah Deshpande, again from my place. So really happy to have her here. And she's a fetal medicine specialist with an OBGY background. And then we have Dr. Bharat Pawar and Dr. Sudesh Doshi, who are clinical obstetricians. Dr. Ranjit K Kerser and Dr. Vandana Gandhi are, obstetricians with special interest in fetal medicine. And then we have two esteemed neonatologists, Dr. Praveen Chinde and Dr. Manish Rani. So I'll point out a question to each one of you, and but everyone else, anybody wants to come in at any time and put in their inputs, they are always welcome to do that. Now I begin with, I would like to start by saying that when we look at us, the obstetricians and the radiologists and the fetal medicine specialists, we belong to three groups. In Group A, the people belonging to Group A have a complete understanding of all the concepts of fetal growth restriction. They know, they understand the perfusion and the diffusion and the cascade and everything, but they do not follow protocols. There is Group B, which has limited understanding of the concepts, but they know, okay, these are the protocols which have come from literature, but they follow protocols. And there is Group C, where they have a complete understanding and they follow protocols also. Now this Group C is very, very limited actually. There are very few people who belong to Group C, but most of us get divided between Group A and Group B. Now, if you look at the overall results in practice, you will find that people belonging to Group B will overall have much better results than Group A. The Group A would maybe one complicated case they would do very well, but overall it would be the group which follows protocols. So the essence of this panel discussion, we are going to talk about protocols, and we will see how protocols really help us. Now, before we get into the clinical aspect of FGR and all, let us, why all this is so important. Let us ask our neonatologists, what are the immediate postnatal and long-term abnormal outcomes in preterm FGR? Are we doing enough for that? Dr. Shinde.
Yes. So, good evening, everyone. Can everyone hear me?
Yes, yes.
Okay. So here we are starting with discussing management dilemma in our preterm FGR babies. As far as immediate postnatal, perinatal outcomes are concerned, we may face many potential complications in these babies, such as like neonatal deaths, maybe intraventricular hemorrhage, then remote complication due to chronic hypoxemia, NEC, perinatal depression, macronation aspiration syndrome, then persistent pulmonary hypertension, hypoglycemia from depletion of glycogen stores, then hypothermia from depletion of fat, subcutaneous fat, especially brown fat, polycythemia owing to chronic hypoxemia, neutropenia, thrombocytopenia, maybe hypoglycemia, hypocalcemia as a metabolic abnormality, then various respiratory conditions like respiratory distress syndrome and such a many immediate neonatal complications we can face in such babies. In short, as compared to appropriate for gestational age babies of same gestational age, AGA IUGR babies have higher incidence of neonatal morbidity and mortality. As far as long-term outcomes are concerned in such AGA and IUGR babies, which are maybe higher, they are high risk for poor postnatal outcome, neurological impairment, renal impairment, delayed cognitive functions, poor academic achievement, and finally, some IUGR, AGR babies may have higher risk of remote coronary heart disease, stroke, maybe in obstructive pulmonary diseases in long-term life. Maybe we call it as a fetal origin of adult diseases. So we need to prepare for such outcomes while managing in such babies.
Thank you, Dr. Shinde. And, from what, he's already scared us right in the beginning. So after hearing all this, now, Dr. Doshi, I won't say, is it important? But I would say, how important is a diagnosis of FGR? My second part of the question is more important. Are we really doing enough for that? Because Dr. Shinde has already taken us through that these are all so much of complications an FGR baby may have, if not delivered on time, in the sense neither too premature nor too hypoxic. So, but how important is this diagnosis, and are we in India doing really enough for that?
Frankly speaking, nowadays, yes, really we are doing and taking a great efforts collectively as far as obstetricians. And
I would address this question to Dr. Sudesh Doshi.
Sir, Sudesh Doshi sir has not joined yet.
Okay, no problem. Let's hear it from the neonatologist then.
Yes.
Yes, Dr. Shinde, please.
Okay, sir. See, nowadays we are really in India, we are really going, taking good efforts collectively as far as our obstetrician and radiologists, including our esteemed neonatologists are concerned. So we are really doing good enough to for managing such a cases of FGR in our now clinical setting. As far as data from all international authorities are concerned, they already started, yes. As far as our neonatal field is concerned, we are lacking behind 25 almost years behind all these Australian and UK countries, European countries. Maybe you remember Newton, Isaac Newton, then great artist Pablo Picasso, then maybe Sir Winston Churchill, the past PM of Great Britain. These internationally accepted authorities are also preterm small for gestational age IUGR babies. But yes, due to the good clinical work, good clinical conditions, and esteemed efforts from our medical field, they are staged a good life in their successful career. So yes, we can do here also. So we are doing enough.
If you look at this chart, if you look at the prevalence of trisomy 21 on one corner and severe FGR on another corner, you will find that the prevalence of severe FGR is far higher as compared to that of trisomy 21, 18, 13. And 26% of Indian fetuses are SGA, are small fetuses. But now if I look at this chart and if I look at what we've been doing for the last few years, we've concentrated so much on screening for Down syndrome. We are putting in a lot of our resources, money, time, energy. I'm not saying that's not important. It's very important. But at the same time, if you look at this prevalence, I feel as compared to what we've been, concentrating on trisomy 21, as compared to that, we are doing very little for severe FGR. We are doing very little for preeclampsia. We will get a double marker done for T21, but we will never get an PLGF done for screening for preeclampsia. So somewhere down the line, yes, the changes have taken place. If you go to any conference, you will find one complete day on NT scanning, or you will find one session on fetal heart, one session on fetal brain, but you would find one or lectures somewhere on Friday evening on FGR. But that has changed in the last 2-3 years. Now we are doing enough. We have really, like this whole webinar today is on FGR. That itself speaks that we have moved on from other things, and we are really looking into FGR very seriously. Now, Dr. Vandana Gandhi, the whole concept about this is a small fetus. Now, what is a small fetus? How do we define FGR? And how do SG and FGR differ in their clinical course? There are 3 questions. You can go one by one, ma'am.
Any fetus which is below estimated fetal weight with 10 percentile, we say it is a small fetus. So it is the first alarming signal on the growth chart where the EFW falls below 10 percentile. But FGR is a specified definition. It is a condition in which fetus fails to attain its genetically determined growth or growth potential. So the ultrasound estimated fetal weight is below 10 centile for that specified gestational age.
Is every small fetus FGR, ma'am?
No, they are constitutionally small fetuses which are healthy. They are only small but healthy, and they show normal growth. They are not pathologically problematic fetuses. So they may be small in weight as well as their growth potential, but they are not problematic like FGR.
So, the biologically determined growth potential. Now, this is a concept which is actually difficult to gauge, and hence actually we are, we are using size as a proxy. And somewhere in between, as we go through, we will come up with something on this, that is size the ultimate factor there. And, so why is it so important to differentiate between the constitutionally small, that is SGA, and FGR?
Because constitutionally small fetuses follow the growth pattern and they do not have perinatal complications as compared to the growth restricted fetuses who land in those so many listed complications which just Dr. Shinde has elaborated. These are compromised fetuses, and so these fetuses land in perinatal mortality as well as morbidity, and we are worried for them. That's why it is important to differentiate so that the management will change.
FGR babies, we really don't want to take them up to term. SGS, we can take them up to full term, up to about 40 weeks. And FGR babies, once diagnosed, we really want to see to it that, we don't end up into the last final 1 or 2 weeks where things can go wrong.
We have to keep a watch and we have to monitor, and we are worried for these fetuses actually as an obstetricians, because end result, we don't want to land up in some mortality or morbidity.
Yeah, Dr. Ranjit K Kerser. Now you have a fetus, like Dr. Gandhi said, that a fetus with an estimated fetal weight which is less than 10 centile. She also said that it is important that we differentiate between the two. Now you have a fetus with a estimated fetal weight less than 10 centile. When will you call it FGR and when SGA?
Yes. Good evening, all of the listeners. I am very much happy to have Dr. Vimal Sahni sir on this platform. For the first time I am sharing this this webinar with you, sir, and I am really grateful to you because on my E6 machine all the settings, especially for pulmonary vein and pericallosal artery, are from you. So thank you very much. I am also delighted to have Prarthana on this webinar because I was with her working in my residency. So I am very delighted to see her also. And I am very thankful to Aclus OBGY Society for giving me this opportunity to share this webinar. Thank you so much. Now coming back to your question, sir. If the estimated fetal weight is in between or less than 10 centile with normal Doppler, then we need not worry. It is simply the small for gestational age. If the estimated fetal weight is less than third centile, then definitely it is a FGR baby. And if the weight is in between third centile to 10th centile with abnormal uterine artery Doppler or CPR, cerebroplacental index or ratio less than 5th centile, and uterine artery PI more than 95th centile, definitely the baby is FGR.
And as you rightly said, that if it is between the third and the 10th centile with normal Doppler, we call it as SGA. Yeah. Dr. Pratna, is it important to classify FGR into early onset and late onset? Means
yes, surely.
Yeah.
Yes. First of all, I would like to take this opportunity to thank Aclus OBGY Society, Dr. Vandana Gandhi, for involving me in this really interesting and updated type of subject. As Dr. Bimali Sahani sir has rightly pointed out that this is really need of hour. And I am feeling honored that I am one of the panelists where sir is moderating the session. So the questions are going to be tough for us to answer, but we are going to get right answers at the end. So coming back to the question, yes, it is really important for us to differentiate between early onset and late onset FGR. The reason being we are looking here at two different phenotypes. The association with preeclampsia is different in both conditions. The fetal deterioration rate is going to be different. So there are various aspects which are usually different whenever we consider the diagnosis, the etiology, associations, and the management part. So unless we are able to differentiate between the two, we are not going to help salvage these babies in a proper way. As our neonatologist sir has pointed out, the complication rate we know is huge. So the antenatal management part, which is obstetrician's responsibility, it's very important that we understand this concept and hence we can manage them in a better way.
And what cutoff do we use? 32 weeks. What cutoff do we use?
32 weeks, sir. 32 weeks should be the cutoff to differentiate between early onset and late onset.
32 weeks at the time of diagnosis.
Yes, yes.
So if a FGR is diagnosed before 32 weeks, we call it early onset. If we diagnose after 32 weeks, we call it late onset.
32 weeks by dates and not by the sonography. Sorry.
By gestational age.
Yes,
that's
yes.
What Sachin has said right in the beginning is the gestational age that is important. And now this 32 weeks actually is a very arbitrary cutoff, because if the patient has come to me at 33 weeks and if I find FGR, now I don't know what time the onset of FGR was. Now, though by definition it doesn't work out, but in practice, if you find at around that time, if you find that the umbilical artery is abnormal, then it is more likely to behave like an early onset FGR. Because in late onset FGR, the umbilical artery, of course, will become abnormal or may become abnormal, but much later. And most of the times in the early part, it is quite normal. So we can use that also as one of the way you differentiate between the two. Now, Dr. Ranjit K Kerser, what is the consensus definition of early and late onset FGR?
So it can be divided into two parts, like solitary, a single criteria like AC is less than third centile or estimated fetal weight less than third centile.
This is what you were talking about, early onset, right?
Yes, early onset. And the umbilical artery, if there is absent endostolic flow, it is straightway the early onset FGR. And AC or estimated fetal weight, if it is less than 10 centile with either or uterine artery PI more than 95th centile or umbilical artery PI more than 95th centile, then you can take these babies also as early onset FGR.
And for late onset?
And in late onset, the solitary factors are AC or estimated fetal weight less than third centile, and at least 2 out of 3 should be there as a contributory factor for late onset FGR, like AC and EFW less than 10 centile, AC or EFW crossing more than 2 quartiles, uterine artery PI more than 95th centile, or cerebroplacental index or ratio less than 5th centile.
For all those who are not aware, one quartile is 25 centile. So what Dr. Ranjit is saying, greater than 2 quartiles. So if there is a drop in the estimated fetal weight or AC
Yes.
of more than 50 centile, so the whole idea is that, suppose the fetus was growing at the 70th centile and has now come to the 20th centile. That means the fetus, the growth has dropped by 50 centile. So now if I go by the definition, because it is at the 20th centile, I can't call it as FGR. So that is why this issue is there. We will come towards it that, we will come towards the end on this, that it is not, even AGA can be FGR. So, but he's rightly pointed it out that, these are the Delphi consensus, which actually ESOG has also adopted this. Now we will see this as we see cases also. Dr. Bharat Pawar, now when it comes to
Yes.
management and decision making in FGR, how are these decisions taken? Is it on personal experience or I don't know, because you're a practicing obstetrician, have everyone actually become aware and are following some stage-based protocols, which in the last 3 years of webinars and everything has already been talked about so often?
No, sir. Initially, as you have told, hello.
Yes, sir.
Am I audible?
Yeah. Very
good. Initially, as you have told, very few people are there of category C. Those who have understood and are following this, but still many are coming to category B. From category A, many have come to category B, and they have started following the protocols.
And so is the Barcelona protocol is the one which has become really popular?
Popular, yes, sir.
Yeah, because they are very simple algorithmic approach, easy to follow protocols, can be followed by everyone. There is an app which is available. If you download that app, you put in the findings, it tells you whether this is pathological, this is not pathological. It also tells you deliver or follow up after a week or 2 weeks. Now, life has become very, very simple.
Easy. Yes.
See, FGR as such, honestly, if you look at it, there is no consensus in the world. What I speak, first of all, what I'm talking today, maybe 2 years, I may come and say that all that I spoke about 2 years back has all gone wrong. And then the evidence which comes also is not helping us. It's too complicated. And then all this evidence which is coming from abroad. And it is also coming from institutions and institutional practice. And most of us are into private practice. Now, so it is very difficult at times. Now we say that the velocity drop, a 2 quartile drop. Now in practice, it is so difficult because the first scan has been done by someone else. The second scan has been done by someone else, anomaly by a third person. The growth, the previous 2 growth scans have been done by, and you may probably be doing the last one. Now, we know there is no real standardization that everyone is following. And that is why it becomes very difficult for anyone to really put their biometry and then see whether the drop is really there or not. And that is the reason, though there is a strong lobby which says that we should not do Doppler for everyone, it is becoming very, very important for us because we don't know what growth chart to follow. We are all following different growth charts, and hence we really take the use of Doppler in handling this. Now, Barcelona has come up with staging, FGR staging based on Doppler. Pratna, can you just tell us what are the stages?
Basically, Barcelona has come up with these 4 stages, and that is to help us to differentiate between what pathology is going on the fetus. So we as know that in the fetal growth restriction, the initial change is in the oxygen supply. That is the hypoxia part of the placenta. That is the respiratory function of placenta is getting affected. So the initial first 2 stages are hypoxia, where it is mild to moderate. That means mild placental insufficiency and severe placental insufficiency are the stages 1 and 2. So these will collaborate with the changes in the similar Doppler. That is the uterine artery PI, where it is crossing more than 90 percentile. So we know the resistance is increasing here in placenta, which is manifesting in the fetus by umbilical PI more than 95 percentile. So it is severe hypoxia. Now the stage 3 and 4 are the more severe stages, where we know that the acidosis has taken place, and hence what we can see here are the changes in the ductus venosus, that is the right atrial, the right ventricular side part of the fetus is swelling. So there is a reversal in the umbilical artery, and the ductus venosus is showing more than 95 percentile changes. And the last stage is stage 4, where it is severe acidosis. So we know that very poor outcomes in these cases if we don't interfere, which is manifested by reversal of the A wave in the ductus venosus, and most importantly abnormalities in the CTGs, because CTGs will show the changes in the brain of the baby. So heart and brain, these are the 2 organs which we are monitoring with the use of these Dopplers and assessment techniques.
Thank you, Prajna. Now when we think about managing, especially the early onset FGR, very honestly speaking, you have to make a mental fight, and the neonatologist will agree to that you have to fight between prematurity and hypoxia. You have to think that at this moment, what is more dangerous for the fetus? Is it the hypoxia which is more dangerous, or the prematurity which is more dangerous? I normally like to explain this in the form of a story of a building. There is evidence to say that before 28 weeks, every day the fetus spends in utero, the morbidity decreases by 2%. And from 28 weeks to 32 weeks, every day the fetus spends in utero, the morbidity will decrease by 1%. So our aim is that we need to allow the fetus to remain in utero for as long as possible. At the same time, we have to see to it that they don't become acidotic or they don't become severely hypoxic. And so to explain this, just imagine that this is a building. This is a high-storied building, and you are on the building. Now the building has caught fire. Now whether to jump or not to jump. So the floor is the gestational age, the fire is the hypoxia or the acidosis, and of course there is a safety net, which actually Dr. Rani and Dr. Shinde are the ones, the NICU neonatologists who are available. Now, whether to jump or not to jump will depend upon which floor you are on, and at the same time, also important is how severe is the fire. Now, if you are on the 14th floor, that is, say, a 26-weeker, and there is a fire, what I will do is I will look outside the window and first see how far the fire is. And if the fire is still far away, am I going to jump from the 14th floor? I know if I jump from the 14th floor, there is a very good chance that I may not survive. The fire is still not strong enough. So what I do is I start climbing one floor down, start going one floor down. But again, it is not that, I'm just running down. Every floor I come down, or every 2 floors I come down from, depending upon what I had seen, the severity of the fire, I keep opening the window and checking out where the fire has, how far the fire has come. So now if I have climbed down 2 floors to the 28th week, and I'm checking at the window and I'm seeing that the fire is only up to the 7th floor. 12th floor is still dangerous for me. I will still, maybe call up the safety net, the fire brigade, and talk to them. They will say, okay, why don't you go a little further down? And then I will look, I will go one more floor down. And then if I go onto the 10th floor and the fire has reached the 8th floor, now that is the time I know that no problem, I'm on the 10th floor. But if I don't jump now, anyway, I'm going to die with the fire. And that is exactly what we use in the decision making. But suppose I'm on the 3rd floor, and even if I smell smoke, which is very little, the stage 1, something very, very minute, I know there is a safety net available. I know I'm on the 3rd floor. What will happen? Maybe I'll break a small finger or something which can get repaired. But at that stage, I don't know what is the speed with which the fire is coming in. And that is what Sachin Natije also he said in the beginning, that like in early onset, the cascade we know, late onset, when we come closer, it doesn't follow any protocol. Things can go wrong anytime. So if I am already at 37 weeks and even there is a small fire there, I will still jump. So this is the complete thought process that you need to use. And once you use that, you will find that decision making becomes very, very easy.
Very beautifully you have made this parallel corollary with the fire and the floors. So we know that at the end of 37 weeks, we are very near to the fire, but we are very easy to jump. So that is a very nice message, sir. I must appreciate highly.
Thank you, ma'am. Now, Dr. Rani, you're a neonatologist. Do the clinicians involve you in the decision making for when to deliver? Dr. Manish? Is he there? Yeah, he's there. You're not audible, Dr. Manish.
I'll call him, sir.
Yeah.
There was some problem in his connection. He will join again. He will rejoin.
Okay. I will come back with this question. We can always have this question again.
Yes, sir.
Yeah, we are already into this thing. So now with this background of the story which I told you, this fits in very well with the Barcelona staging. Dr. Vandana Gandhi, can you explain the Barcelona protocol for, staging? Pratna has already told us, but how do we use that protocol for surveillance and delivery decision in early onset FGR?
It is exactly similar on the protocol of your ladder of weeks and the fire. Exactly same way we should go. The Barcelona protocols have given us staging according to the severity of the hypoxia. So according to the severity of fire, as we are approaching towards the maturity, we need to have a balance of monitoring, that is surveillance, as well as gaining maximum maturity with least risk. So if we are having the stage 1, that is a mild placental deficiency, and if we pull on up to 37 weeks, that is the 3rd floor, then we can monitor with the Dopplers per weekly till the CP ratio is up to 5th percentile or less, and till the end diastolic flow or till the ductus venosus is normal, we can pull on up to 37. And in this stage, we would like to give an antenatal dose of steroids and deliver.
So as long as it does not reach 37 weeks and maintain stage 1, we will pull on.
We will pull on up to for the betterment of the maturity, so that even if it needs an NICU, that journey will be a smoother one. When the baby is in stage 2 of Barcelona protocol, that is, there is severe placental insufficiency. Already there is absent end diastolic flow in umbilical artery with reversal of aortic isthmus. At this stage, we need a close monitoring, that is twice a week. If it is up to 34 weeks, we can pull on. And if the Dopplers are not deteriorating up to 34 weeks, Then with this close monitoring, we need to decide further along with the biophysical profile and amniotic fluid index and the fetal weight. Means I want to correlate all factors up to the severity of the, up to the safety of the baby and maturity. So it will be closer monitoring. And again, the dose of antenatal steroid will be preferred. When baby is at the third stage, that means already there is a reversal in umbilical flow, as well as the ductus venosus is about 95th percentile. It means there is a suspicious or early onset of acidosis. In this, we are actually on the dilemma of deliver to not deliver. And in this stage, again, the ductus venosus will be a deciding factor. Until it is not reversible, we have to close monitor. At this stage, I will admit the patient so that every alternate day we can do the Doppler monitoring, NST, amniotic fluid index, and then pull on 30 weeks or beyond will be a decision as per the individual patient and obstetric indication. And in the stage 4, I think that we should not allow the baby to go in the stage 4 because it is an reversal of the ductus is an ominous sign. And it is, I have heard that once there is reversal of the ductus, we expect or predict the fetal demise in 24 hours. So without getting the baby in stage 4, we should decide to monitor every day or twice a day. And maximum we can pull on up to 26 weeks. And if it is a reversal, we should deliver promptly. So this staging helps us to clinically correlate to attain the maximum maturity with least risk of the fetus.
Before 26 weeks, delivering the prematurity would be too harmful. So 26 weeks with a good NICU setup, otherwise 27, 28 weeks is a good time. So to make it, Barcelona has made it very simple that if it is a stage 1, 37 weeks, you did 37 weeks
do induction of labor
to deliver. If it is not 37 weeks yet, but stage 1, you do weekly monitoring. If it is stage 2 and so 34 weeks, absent diastolic flow, if there is an absent diastolic flow, and if the fetus has attained 34 weeks, you need to because that time the hypoxia is going to be more dangerous than the prematurity because 34 weeks is good enough. If it is not 34 weeks, then with an absent diastolic flow, but with an absent diastolic flow also, now the new guidelines which have come up from the FIGO, this thing, they said that even at 32 weeks also, with an absent diastolic flow, you may take a call on delivering. And then otherwise you monitor it bi-weekly because, we know the fire has reached quite high. So what I would do is rather than going down one floor, normally the stairs are like this. You go like this and you go like that. So there are windows on both the sides. So halfway through also I will peep in and check whether things are going bad. But if it is stage 3, even if it is 30 weeks, yes, you give, because a chance of the fetus baby coming out with acidosis, the chances of the baby doing well will be better if the baby is brought out. And if it is stage 4, yes, actually any time you have to give a call, like Dr. Gandhi said, that if you have the A wave reversal in ductus venosus, you just cannot pull on. But then again, you have to give them the best chance as far as the fetal weight is concerned. So 26 weeks is something which we really need to look into. Now,
so at this stage, I would like to add one point. This is a very critical position of the baby. And as a clinician, we need to counsel at this stage because either way we are in danger, either keeping the baby inside or delivering the baby. We cannot predict the outcome. The relatives or the patient expects from us that we are interfering, means it is in the best purpose of the baby survival. But this we cannot assure or guarantee that. So the counseling is a great part considering the medical legal issues concerned with the sudden IUDs or even neonatal deaths or NICU complications.
In such cases like stage 4, multidisciplinary, and if it is 26 weeks, 27 weeks, multidisciplinary counseling is what actually is required. And the final decision should always be the parents. You can always tell them, ek taraf thaiye, ek taraf hua hai. Both ways things can go wrong, and also explain them the complications that can occur, even the baby would have to spend a lot of time in the NICU. The cost involved, they need to prepare for all those things. And as you rightly pointed out, counseling, actually everything in OBGY now is counseling, ma'am. Those days are gone when we used to dictate terms. Now, even with for every small thing, even for if you want to the fetus, the parents to go and screen for aneuploidy, ideally speaking, you need to counsel them and let the parents decide whether they really want to screen for Downs or not. A parent can opt out, no problem, but I don't want to screen for Down syndrome. So counseling is becoming the most important.
And especially in peripheral places like ours, like Akluj, where we don't have a dedicated fetal medicine expert. So we need to have an well understanding with the neonatologist and parents and the consultant gynecologist. All should be in one stage to counsel, so that all the queries will be handled individually in front of both, because both are, it is a teamwork, both are handling that. So it should be a team counseling with the parents.
This is a complete flow chart from Barcelona. I think everybody should have this on their table, so that it gives us everything, even the mode of delivery and the gestational age at which delivery should take place. And Dr. Bharat Pawar, what is the critical endpoint to deliver a fetus with early onset FGR?
Ductus A wave in ductus venosus, absent or reversed A wave, or if there are deceleration on CTG or altered BPP with a score of less than 4.
Because these are changes which eventually, there is a very strong possibility of a demise taking place in the next 12 to 24 hours. And hence, this becomes a critical endpoint. If prematurity is an issue, I will move till I go to the critical endpoint. But I will have to do a much more closer surveillance and monitoring that is required. Dr. Sudesh is not there. Has he joined? Dr. Doshi has joined?
No, not see.
Not yet, sir. But Dr. Manish Rani is there now.
Yeah. Someone, Dr. Manisha, can you take this? How do you manage the surveillance and delivery decisions in a case of late onset FGR? We saw this. This is very nice for early onset. It's quite true, but then because this is so based on umbilical artery, the whole cascade is based on umbilical artery, but in late onset FGR, as I said, umbilical artery may be normal, and hence, how do we take decisions in late onset FGR?
If umbilical artery flow is normal, we can go for monitoring CT, NST, non-stress test, and daily fetal kick count also. If the patient does not perceive movement, or there is a less DFKC, and if there are abnormalities on NST, we can go for the next. We have to decide. We have to take a call. Depending upon the gestational age. If it is more than 36 weeks, we have to deliver. Considering the obstetric history, if she is a primary or a previous LSCS, cervical scoring.
You have a fetal weight which is less than 10
and
centimeters.
Also biophysical profile.
Yes.
I think we should go by CPR.
Biophysical profile.
And all these things will come later, but the first thing which actually catches your eye is the CPR.
CPR.
Have an umbilical artery which is normal. See what happens in late onset FGR. It is not that there is no placental disease. There is a placental disease, but it is not severe. It is not severe. And because it is not severe, the perfusion does not get hampered, and because of that, the umbilical artery may not get hampered. Somebody has to mute. Somebody is speaking in between. Yeah.
Done, sir. Done.
Yeah, and that is the reason you may have an umbilical artery which is normal, But because there is a placental disease, even though the perfusion is normal, the diffusion is not normal. And hence, the oxygen deprivation definitely takes place. And that is why there is hypoxia. And that would get manifested by a CPR becoming less than the 5th centile. And you may get an MCA PI which becomes less than 5th centile. So in late onset FGR, you have, once you have said that this is less, fetal weight is less than 10th centile and the CPR is less than the 5th centile. Of course, if it is less than 3rd centile, we will call it as straight away. But even if the CPR is less than 5th centile, along with the fetal weight less than 10th centile, I would like to put them into very closer follow-up. And there is no literature evidence yet how should be the surveillance in late onset FGR. But I would like to monitor them on a weekly basis or a bi-weekly basis, depending upon how closer to term I am. And if I need to see whether the DPR is, the CPR is dipping down, and at the same time look for fetal breathing movement, the fetal movement count, you have to talk to the patient. And if you find that the biophysical profile is abnormal or the CTG is abnormal, then you have to take a call on delivering. But otherwise, you can keep monitoring, and with a CPR which is abnormal, you can deliver at 38 weeks. That is what the evidence says. But whatever evidence says that, okay, don't use CPR for a trigger for delivery. Use it for a trigger to say that this fetus requires closer surveillance. And that is why your NST and your fetal breathing movement and all those things become very, very important. But I have also noticed in clinical practice is that if you have a rapidly dipping CPR, your CPR is like, okay, on the 4th centile, and suddenly you find that it has gone less than 1 centile in a week's time. These are the ones which you have to be more careful. And maybe at even 37 weeks, you may think of delivering them. Though evidence says that, okay, don't use CPR as a trigger for delivery, use fetal breathing movement. And but then they also say that then do it daily, do it twice a day. Now, again, that is what I say. These are institutional things. As an obstetrician, are you going to send this patient to me for a Doppler twice a day, or tell me that, okay, now do a biophysical profile twice a day? It doesn't happen in real life scenario. And that is the reason, in private practice, in the scenario that we work in, unfortunately, we don't have Indian guidelines. We don't have Indian guidelines. And all these guidelines which come from are coming from institutes which are nobody uses NST in the best institutes. They're using computerized CTG. I have not used a word of that because I know we have got only 2 CTGs, computerized CTGs in India. But otherwise, if you look at the current evidence which has come in, the current guidelines, they've all talked about, nobody has spoken about the NST, they've spoken about the computerized CTG. And so that is where we really have to see, because I told you one story about the floors. Let me tell you one more story. Now, there is a person, a very rich man, he wants to employ a driver. So he gives an ad and all the drivers come. He takes them towards a cliff and he tells them, let me see who stops closest to the cliff. So you drive down towards the cliff and stop just as close to the. So people go, somebody stops 1 feet before, somebody stops 2 feet before the cliff. There's one sensible gentleman, he stops about 10 meters before the cliff. And he says, you are not, you're out of the race, you are far behind. But he said, sir, I don't know how deep, how deep the cliff is. I don't want to take this chance at the end. I have brought you till here. I know you can walk down the last few steps. So why do you want me to take you all the way there and risk your life? So that is exactly with late onset FGR. We know that late onset FGR, things can deteriorate very fast. If 40% of the IUDs that occur at term are because of late onset FGR. We have to start accepting those facts. So don't use CPR as a trigger for delivery, because CPR can be very deceptive. Your MCA PI can be very deceptive, because always repeat an MCA PI after 24 hours. Don't go by a single reading. Even within, all those who are doing ultrasound would know, or those who are doing Doppler, that within a span of 1 hour, if you take an MCA PI 3 times, you will find a huge variability in that. So if you feel that the MCA PI is less, you repeat a scan after 24 hours and confirm it that yes, it is persistently less there. And if you have an abnormal biophysical profile, abnormal CTG, deliver. Otherwise, consider delivery at 38 weeks. Now, this is what the, sorry.
Sir, can I add one more thing?
Yes.
Just to stretch your story bit far, why to extend this pregnancy beyond 36 weeks if at all we know that the baby's weight is less than 10 centile and the CPR is less than 50 centile. So do you feel that instead of increasing our heart rate and anxiety, let that baby get out of the womb at 36 weeks itself?
There is a strong lobby which is not very happy with the CPR as a criteria to deliver, because they say that use CPR as a means to put the patient onto closer surveillance, because you know, there is a difference between 36 weeks and 38 weeks also as far as the outcomes are concerned. Maybe it's not about just fetal demise, but definitely babies at 38 weeks do better than 36 weeks. And hence, if you have a CPR which is less than the 5th centile, as I said, CPR can be very deceptive also. And if you have good breathing movements, you have everything like that, then definitely you should try to pull it on as much as possible, you know, up to 38 weeks.
I think Ranjit, by going to 36 weeks will be a very earlier to decide only on CPR. And if we are sure as a clinician on our part, because we are monitoring all other things also along with CPR. And we know the bad obstetric history or any other patient's bad history in the obstetric career, then overall we have to take the decision. That is my take. As far as maturity, even why 36? Even if you go by antenatal steroid in 37, where by every day baby is attaining some weight. Until there are more than 3 high risk factors, I would not go for 36. I would stretch up to 37, 38 weeks. At least borderline prematurity is acceptable.
One more thing I wanted to just add here, whenever we talk about late onset FGRs, what we are worried about is the hypoxia component and not the acidosis, because we will not let this baby go till acidosis. Exactly. And we know that the late onset FGR, these babies are sensitive to hypoxia, and hypoxia, especially the brainstem part of it. So NST still I can consider that what many of us as obstetricians are using, the variability in NST will definitely give us clue about the CNS functions. And most of us do the growth scans in our centers. So if we are not able to do BPP, the whole biophysical profile may not be possible for each and every one of us. But looking at fetal breathing movement, because respiratory center in the brain is the one which is really sensitive to the hypoxia. So the first thing that will go in a severe hypoxia will be breathing movements. That is one we can monitor in our own setup. CTGs, NSTs we can do in our setup. So as long as these two findings are giving us that yes, the brain is not going in severe hypoxia, we can definitely continue monitoring in our own centers also.
So in this gray zone, we cannot only rely on CPR. We have to take the multiple parameters also. That is important to take multiple parameters other than only CPR or only amniotic fluid index. We have to do the BPP, NST, because usually all private hospitals do have NST now.
So even the ISO guidelines, they say that after 36 weeks, if you find that the umbilical artery is high or fetal weight is less than 3rd centile, yes, go ahead and deliver. But if you find that you know, estimated fetal weight less than the 10th centile, umbilical artery is normal, which in most of the cases can be, then signs of cerebral redistribution or any other feature of FGR you are seeing, then 38 weeks is what is recommended by the ISO guidelines. And I would say in practice, 37 to 38 weeks is a decent time to get these babies out here. Now, Dr. Vandana Gandhi, this is what I was talking about. Is fetal smallness the absolute marker for adverse perinatal outcome? we said in the beginning, I asked you and you said that yes, all SGA fetuses are not FGR. But I'm asking you the question in a reverse form. Are all FGR fetuses SGA?
No, that's why they are not the absolute marker for adverse outcome of the perinatal period, because we are monitoring, and there are so many tools in our armamentarium that we have so many Doppler values and indices that other than EFW, these all CPR and umbilical artery and ductus venosus are the parameters which can give us very good monitoring. So we cannot alone go with the EFW.
If you see this chart, you will find, yes, the maximum mortality is when the estimated fetal weight is less than the 5th centile, 3rd centile, or up to 10th centile. But if you look on this side, you will find that, yes, even otherwise also, even the fetuses which are AGA, they can also have a fetal growth restriction. Now, that is why they came up with that velocity dip and all. As I said, in real life practice, it is very difficult to define the 2 quartiles and all those things. And hence, if the fetal weight is less, between the 10th and the 50th centile also, if it is more than 50th centile, you will find that, yes, the mortality is not very high. But even between 10th and the 50th centile, you do Doppler. If you find that the CPR is less than 5th centile or the MCAPI is less than 5th centile, put them on surveillance. Just don't. And if you're doing a scan at 32, 33 weeks, and if you find that the CPR is less and the fetus is AGA between 10th and the 50th centile, you'll say, okay, no problem. This is not FGR. No, put them on surveillance. A fetus which is AGA at 32 weeks may become SGA at 36 weeks.
Exactly.
Because, like Prarthana said, later on in pregnancy, the hypoxia element becomes very important. If there is a graph, actually the placenta gives nutrition as well as oxygen. The nutritional needs, they grow exponentially. But you will find the graph of the oxygen need, you will find that suddenly after the 3rd trimester, it starts going up. And hence, because the perfusion is normal and because the fetus has already reached 32, 33 weeks with sufficient amount of nutrition, the fetal weight may not have gone less than the 10th centile. And hence, these are the babies also you need to keep a watch on, put them on surveillance. You can put them on weekly evaluation. And finally manage them as late onset FGR. If you
as
find
Prarthana said, sir, that these babies of late onset IUGR are more sensitive for hypoxia because they are not adopted as like the early onset, and hence these are at more danger, and we need a serial ultrasound, serial Dopplers, and then the decision along with all factors.
What happens is, madam, the early onset ones, they can tolerate hypoxia for a very long period of time, and that is why the heart gets a lot of time to to push in more blood, and eventually that is why in early onset we use DV as the endpoint, because the heart is eventually failing. But in late onset, because they cannot tolerate hypoxia for a long period of time, the heart doesn't get enough time to work, and the brainstem is very responsive to hypoxia later on, and that is the reason we, it's a happy heart stage. The heart will not show you. The ductus venosus you cannot rely on. So you have to rely on the brainstem findings. And for that, yes, the first thing which becomes abnormal is the respiratory movements. And that is because the tone and other things would come up later. And then oligohydramnios and all, there is evidence which is coming now that if a pregnancy is being monitored by Doppler, then oligohydramnios by itself does not really correlate well with abnormal outcomes. For pregnancies which are being monitored by Doppler as such.
Very true.
So, Dr. Bharat Pawar, after listening to all this, should a scan at 30, 32 weeks and 36 weeks be a part of the protocol in every pregnancy?
Yes, sir, it should be.
And should Doppler be a part of all growth scans?
Yes, sir.
Without doubt.
Without doubt, sir. It gives an early criteria for diagnosing the IUGR babies or FGR babies.
If we diagnose early, then only surveillance is possible. So it is a must part of the protocol.
Paper by Ranjit Akulkar and the Nicoloids group where they've said that yes, doing a Doppler in every scan actually leads to higher intervention, earlier intervention. So there is a group which actually refuses to do that. But for us, the problem is different. See, there are so many growth charts. If I put the same estimated fetal weight in the Mediscan growth chart, I will find that this is AGA. If I put it on headlock, I will find this is SGA. And hence, it is becoming very, very difficult to define AGA and SGA also. Because you may be using headlock, somebody else is using a Mediscan chart, third person is using a Prashant Acharya chart. Dr. Prashant Acharya says that Dr. Suresh chart is a Dravidian chart, my chart is an Aryan chart. So with all this confusion, because now we cannot, these days, the parents have become so conscious, every pregnancy has become so precious, they are coming and doing every scan that is possible, they are following up regularly, and then at the end, if you give them an IUD, it becomes, they're not ready to take it very, very lightly. And hence this should be, so there should be no growth scans without Doppler scans. Like we'll quickly go through some cases to illustrate. Do we have time or do you would need to?
Yes, sir, proceed, sir.
Now, I want my panelists to take a call on what they would do if with this kind of a case scenario. 28 weeks primary has come for a 30-week scan. Fundal height is 26 to 28 weeks, healthy, gained 7 kg since pregnancy. BP is normal. Now, biometry wise, fine ACFL 10 centile, estimated fetal weight is 14 centile. Even ACE is not less than 10 centile. Now, Dr. Vandana Gandhi, is this FGR?
This is suspicious of early FGR because only clinical sign is the less fundal height. Otherwise, we need a surveillance because it may turn on. Because there is a one single clinical sign is also suspicious because why she should have less fundal height. Otherwise, she is normotensive and weight gain is also very good. So she is at very early border of early onset FGR.
No,
she may turn.
Your fundal height can be very deceptive, ma'am.
Yeah, but still, I will have a trigger in my mind that I should keep a surveillance on.
Okay. So, but now with this kind of a scenario that I'm showing you, do you want more information?
Yeah, for this, I would like to compare her dating scan as well as NT scan and TIFA scan to know any structural abnormalities and any uterine artery deviations in the PI values, as well as I would like to know her clinical status that says whether she is anemic or chronic fetal hypoxia may be an additional cause. So maternal chronic anemia, I would like to know her status throughout these 30 weeks.
Okay. Now dating scan was corresponding, NT scan was corresponding normal, uterine artery PI was normal at that stage, anomaly scan was also corresponding, and even the uterine artery PI at that stage also was normal. And you can see that the umbilical are now, as I said, that I do Doppler for every growth scan. So I did Doppler. The CPR is 5th centile. It is not less than the 5th centile. Now is this FGR?
Still, we cannot label it FGR, but I will keep a suspicion to monitor.
So when would
because
you like
I want to compare the earlier values with another values. So she is definitely under surveillance for a serial Dopplers.
So when would you like to do the next scan? Because
after 2 weeks. After 2 weeks.
Okay. Now this patient has come at 32 weeks. Now the AC is less than 10 centile. Umbilical artery is more than 95th centile. The CPR is less than 4th centile. Okay, we are.
So she has shown the deviation at this point. It is evident that she has landed up in early onset FGR.
No,
this is FGR then. And what stage is this?
This is mild hypoxia.
Stage 1.
She is stage 1.
Yeah.
Stage 1.
Yeah, Dr. Ranjit, you wanted to say something?
No, it is stage 1 only.
Stage 1.
So when would you like to follow up?
Weekly.
Again, after 2 weeks, we can follow up because still the ductus has not touched and both umbilical and CPR are...
by definition, stage 1, we should do it after a week.
Weekly, yeah.
Yeah, but this patient did not turn up after a week and he came to me again at 34 weeks. Now the fetal weight is less than the 4th centile. And that is not the problem with patients also. even the clinicians I've realized, if we say that after 1 week, they say send after 10 days. If we say after 2 weeks, they'll send after 3 weeks. Or sometimes the patient also keep pulling on by 3 to 4 days. So that is a routine. Now at 34 weeks, this is ACE is less than the 4th centile, fetal weight is 4th centile, umbilical artery is 96th centile.
She is definitely showing deviations in the Doppler values as well as the biometry. So now she has entered the second stage and now she will need a very close monitoring.
Why second stage, madam? We are not.
So this is first.
This is still
Stage 1 only.
Stage 1 only. Yeah.
Yeah. This is still stage 1.
Okay. Till the umbilical
Weekly
is
umbilical
not
is
absent. Diastolic flow is not absent.
So we follow up again after 1 week. Again after 1 week, you are finding that Dr. Bharat Pawar can come in here.
Yes, sir.
Yeah. Now this is 35 weeks. Umbilical artery is high. That has always been high. Our estimated fetal weight is 3rd centile. This is still stage 1.
Yeah.
We'll deliver her now.
Weekly follow-up, sir. Again 1 week.
So you want to wait for 1 more week. Okay.
Yeah. Ductus venosus is normal.
Again, fetal weight is now 1st centile. Umbilical artery is high, but still no absent diastolic flow. And so by definition, it is still stage 1.
Stage 1.
So would you like to deliver?
Weekly follow-up, steroid cover. I will give steroid cover and wait for 1 week.
At what stage will you give steroid cover now? I want to ask to the obstetricians because see, we know
till
from
39 weeks, sir.
Sorry?
No, sir.
Till
So
39 weeks.
Prophylactic we have to give after 32, 33 weeks.
No.
And for fetal benefit, we give even the full-term antenatal steroid, which is accepted by pediatric part.
No, in this case, I'm asking you.
Sir, already steroids are there, sir. So I doubt
36 weeks is late. 36 weeks is late. We have to consider earlier.
No added advantage of giving. Yeah.
So it should have been given
earlier.
32 weeks.
At 32 weeks.
So
32 weeks. The first insight we should give this.
37 weeks, still stage 1.
Yeah.
Will you deliver, sir?
The CP ratio is less than 1.
Sir, I would like to deliver, sir, because it is during 37 weeks. So why to wait now?
Yeah, even by protocol, you reach 37 weeks.
Yeah,
protocol also says stage 1, you deliver.
Yeah.
Ductus is normal. CPR
is normal.
CPR is less than 1, sir.
CPR is less than 1. So it is an hypoxia.
It will be better to deliver.
Yeah, 37 weeks it has reached and stage 1. You're on the 3rd floor. There is a fire. So 37 weeks, we will deliver. Mode of delivery can be labor induction or the Caesar, depending upon. There are so many other things that they need to take into consideration. So what have we learned from this? That iatrogenic prematurity can be avoided or minimized by evidence-based algorithmic approach and clinical surveillance. So we actually did not hurry up, from 33, 34 weeks, because we were monitoring it regularly rather than, so we could pull on till 37 weeks. And then, so the prematurity aspect, I really reduced.
I have a question at this point.
Yes,
if this CP ratio was less than 1 at 37 weeks, if it would have been prior to 37 weeks, would it be in criteria for delivery?
No, madam.
No.
Mere CP ratio less than 1.
No.
You could use your NST in between, and your DV is normal.
So at this point, what should be the criteria or cutoff Doppler value of either ductus to be reversal or
ductus at any stage, but 36 weeks or 35 weeks, if there would have been an absent diastolic flow in umbilical artery, yes, we would have
to deliver. Yeah.
Because it would have gone into stage 2. And stage 2, we know 34 weeks, we have to, after 34 weeks, we have to
deliver.
So that is how we would have gone by.
For this baby, considering it is early onset FGR, we are not worried about the hypoxia part, madam.
Yeah.
Yes, 29 years, primary, obese, IVF 3rd cycle, early pregnancy scan, 8 weeks. That time she was 7 weeks, 4 days, and the dates were corrected. It was done outside. So now she's come at 19 weeks, 5 days.
Okay.
And I have corrected the dates and you can see that the ACE is less than the first centile and the estimated fetal weight is at the third centile. Dr. Prarthana Shah, is this FGR?
Sir, I would like to know some more information about this child. Based only on biometry, I may not go. I need to know about the uterine artery Doppler. I need to know whether there is any other structural anomaly in the fetus. So how is the anomaly scanned? And how is the uterine artery Doppler?
Because the fetal weight is third centile, ACE is less than first centile, even by solitary criteria, one thing you can say that this is FGR.
Yes. This is FGR, yes.
So you want more information. So I'll provide you that FTS was done outside. It was low risk. And I believe in that report. Uterine artery evaluation at that time was not done. In the present scan, there were no structural anomalies, no soft markers of aneuploidy. But this is the picture that I see on Doppler where the uterine artery PI is very high. And umbilical artery is also showing high resistance flow. The TV is normal. So what stage is this?
Stage 1 only.
Stage 1.
Stage 1 still.
This is stage 1. Okay.
Stage 1.
Now, this patient with all these findings has come to you as a fetal medicine person that, okay, madam, there is an FGR and this thing. Would you, as a fetal medicine person, like to advise anything else?
Sir, if we look at SFMF consult of ACOG, they have clearly stated that any baby with an early onset fetal growth restriction, we should, irrespective of whether we are seeing any structural anomaly or not in the fetus, we should go for the genetic evaluation of the fetus. Because this is an early onset fetal growth restriction, so we have to look it with the microarray instead of only karyotype in the fetus. So that will rule out the genetic association or genetic etiology of the pathology that we are looking at, because the uterine artery Doppler in the NT scan was not done. So we are not aware of what that is. Maybe the present uterine artery Doppler is in normal range.
Is high. The present uterine artery PI is high.
Okay, so it can be a placental pathology also. So we will keep both options open for the further monitoring.
Thank you very much, because I wanted to give this message that you have an early onset. First of all, somebody talked about the symmetric and asymmetric type in the previous lecture. First of all, this is historical now. Symmetric and asymmetric is historical, but it still holds somewhat true in the sense when you see a symmetric kind of a pattern, there is a chance that the cause could be fetal. And when you see an asymmetric this thing. But here, of course, all the parameters are low, but any case of an early onset FGR, which you're seeing at the time of your anomaly scan at 19-20 weeks, always keep genetic issue, because it is not necessary that a fetus with a chromosomal abnormality may not have a uterine artery which is abnormal.
Yes.
No, there could be both the factors there. So that is something which, and most of the time you may find, I showed you that this is obese. There is a strong possibility that, my own evaluation may not be as good as what is expected in a second trimester scan. And hence, now, Dr. Bharat Pawar,
yes, sir.
How will you counsel this patient? Would you advise termination because there is significant FGR which is taking place at this stage itself at around 19 weeks, 5 days?
So guarded prognosis is there. I will not advise termination. Let them decide. As madam said, microarray or a genetic workup should be done of the baby, and then we should decide.
Okay. So, but we will tell them that if
prognostication should be clear at this stage only.
A placental FGR also, which is happening now, we don't know, how. Because there is a minimum of 26 weeks that we require. And so things could go wrong even before that. So we need to make a picture very, very clear with all those people. And then when would you like to follow this up? Anyone can take this. When would you like to follow this up?
Every two weekly.
2 weeks.
2 weeks.
What will you gain? 19 weeks, 5 days, 21 weeks, 5 days. I say, okay, now the DV has become abnormal. What are you going to gain out of it? Means, are you going to deliver that baby if the DV has become abnormal at that stage?
No, but with patients' clear idea about the baby's prognosis, We have to have some evidence, sir, in our hand. We should not declare that it is an IUD now. So before that, 2 weeks scan will not do any harm, but we will have an early diagnosis, early prediction.
There were no structural damages. Torch test was done, which was normal. Patient refused any testing for chromosomal anomalies. It was a very precious pregnancy. They wanted to give the best chance. All pros and cons were discussed with the patient. Being a very precious pregnancy, patient wanted to give a best chance. Now, it is 19 weeks. I know I'm not going to take any call before 24, 25 weeks, at least for sure. So, you can advise, there is no point doing a stage 1 weekly Doppler at this stage and see how things are progressing, unless, something really goes wrong. But anyway, we said, okay, in between requested the gynecologist that when they come for a follow-up, just see whether the heart is beating well, and then we would probably repeat after 5 weeks. But the patient wanted to give, was very well read, had read a lot of things and on FGR, and they thought prematurity would be worse, and they came at 26 weeks, 5 days. And now you can see that, of course, the growth
severe growth rate.
The fetal weight has
less than 5%.
And there is reversal of end diastolic flow. But aortic isthmus is normal, ductus venosus is normal.
445 gram.
Prarthana or Dr. Bharat Pawar, what stage is this?
Stage 2, sir.
Reversal in the umbilical artery, stage 2.
Stage 2. This is stage 3.
Yes. Reversal is stage 3.
Sorry, reversal, it is not absent. Yes, it is stage 3, sir. Stage 3.
Will you deliver? 26 weeks, 5 days.
Again, as we discussed earlier, 26 weeks is in Indian scenario period of viability and the NICU facilities. Considering all this, we have to counsel the couple whether they want to take the call of delivering this baby and being in NICU with all the future complications and the cost involved. If they are willing, then we will deliver.
You're relying on the NICU. So we have the NICU here. Dr. Manish, are you there? Are you audible now? Dr. Rani?
So there is some technical problem with him. So he is unable to speak.
Can I have Dr. Shinde here? Dr.
Yes,
Shinde?
sir. Yes, sir. I'm here.
Yeah. So what would you do in this situation? What would you suggest? Because now the obstetrician wants to put the decision-making buck on the NICU, so they involve you here. What would you say?
We are going to follow our ABC of our NICU. First, I need proper corrective counseling with the parents. All NICU complications, future care, long-term consequences, and most important, expenditure. That is the most vulnerable part of this management. So I need first as far as neonatal is concerned, I need collective counseling, proper counseling for this case. Then obstetrician can take the call with parents' decision.
26 weeks, 5 days. If we go by protocol, it is stage 3. We need to monitor it on a daily basis. Actually,
daily basis.
Yeah, we need to monitor it on a daily basis. But now the patient came directly after 4 days. Now there is a reversal of diastolic flow in the aortic isthmus. The ductus venosus PI is greater than 95th centile, but there is still this thing which is available. There is no absent A wave in ductus venosus.
12 hours.
Ideally speaking,
we should admit it.
You could still, even if you go about in real life scenario. But this patient had read so much about FGR that I learned a few things from this patient. And then they said, sir, this thing is there. We've heard your lecture on YouTube also on the staging and this thing. So they're like this thing. But 27 weeks, 5 days, there is reversal of diastolic flow, reversal of A wave in the ductus venosus. Yes, definitely.
Section. Here you have to do an elective section with the guarded prognosis.
485 grams female baby was born by LSCS. The baby spent 40 days in NICU and went back home. So in early onset FGR before 30 weeks, the critical endpoint should be an abnormality in the ductus venosus. Every day a fetus spends in utero before 28 weeks reduces the morbidity by 2%. And that also we need to take into consideration.
Sir, here one point I want to add. In this situation, when we take a decision of a cesarean section, if the place is having an NICU facility, then it is okay. If it is a small place where NICU is not available, in utero transfer to a higher unit is the time.
Then you need to transfer the patient a
little bit earlier.
Because you know that see we know when it is stage 3, it is not going to last for more than a week. That is what we are going to push into. So at the right time, sending the patient is an important thing.
Yeah.
28 weeks gravida for scan at 29 weeks, 5 days. Fundal height is 28 weeks. She has a history of hypertension from 27 weeks in her previous pregnancy. LSCS was done at 34 weeks, emergency LSCS. The fetal weight was 1750 and the baby is currently alive and healthy. Her mother was also hypertensive. NT scan 12 weeks, 3 days was corresponding. Uterine artery PI was 2.95 increase. Now, I would like to ask Dr. Ranjit, should a PAPA and PLG be added to the mean uterine artery PI at this stage?
Ideally, yes, sir.
Yes, we need to. So how does it make a difference? You're screening for preeclampsia with only uterine artery PI, and then if you add the MAP and the history and a PLGF, does it really increase the detection or the detection rate of the risk for preeclampsia drastically? Dr. Ranjit?
Hello. Sir, Ranjit K Kerser has left. He has apologized because of some medical emergency. His patient is having convulsions.
So yes, you can, but in this case, he has an history of hypertension in the previous pregnancy. So, mean uterine artery PI is already high. And very honestly speaking, all these patients usually have already been put on aspirin before. Yes. So they have already started them. So you need to start them on any medication. And Dr. Bharat Pawar, what is the dose of aspirin? What
150 milligrams, sir.
150 milligram.
150 milligram, preferably at night, should be started before 16 weeks.
At NT scan only.
Why not give aspirin to everybody rather than spending so much time on and money on PLGF and uterine artery and all? How does it really matter? Is gastritis the only reason that we don't give?
Rather than gastritis, sir, it will have the benefit because PI is already high. So that much practically we are not getting severe gastritis, but we'll get that much benefit of ecosprin if we start by NT scan.
I'm asking a general question to you because you're an obstetrician. That why don't you give aspirin to everybody?
No, there are other side effects also other than gastritis. They may have any other site of bleeding and they may aggravate. Some patients do have hyperemesis and they vomit blood and they aggravate by aspirin. If it is not indicated, we should not give. Then what is the difference between mean uterine artery PI help by aspirin and all general population to be covered? Then we will not have any justification over that.
Another reason is that when you do something as like you give vitamins to everyone, iron to everyone, the compliance is not very good. But once you point out that yes, this is you are screen positive for preeclampsia, the compliance will be far better. That is an important thing there.
Madam, one more thing. The first question that you had asked to Sir Dr. Ranjit K.
वो MR से बात करती हूँ, MQR वाला देशपांडे है ना, वो देशपांडे से बात करके वो लेके आ जाएगा.
क्या प्रार्थना?
सिविल मैडम का मैसेज तो आया, प्लीज डू कम बोल के, लेकिन
प्रार्थना was saying something.
कहाँ जा पाएंगे अपन, नहीं जाना होता, कहाँ जाना होता अपना.
Should I continue?
Yes, sir.
Yeah.
Yes.
So 20 week scan was corresponding, no soft marker, no structural anomalies, everything was normal. In light of our history of hypertension and FGR in previous pregnancy, Dr. Bharat Pawar, when would you recommend the next scan?
6 weeks, sir.
26.
Yeah.
Yeah. Okay. 26 weeks. At least 28 weeks. 26 to 28 weeks would be the best time because she has history of preeclampsia. She has history of delivery which has taken place early. Now she comes directly at 29 weeks, 5 days. The estimated fetal weight is at the 5th centile, but the umbilical artery PI is increased and the DV is normal. BP is 170/96, fetal edema, albuminuria. Now, what stage is this?
Stage 1.
Stage 1. Will you deliver?
No.
So follow up after 1 week, and
1
then
week.
comes at 30 weeks, 6 days. Again, you have now the fetal weight is at the 3rd centile. The the DV is still normal. BP is 180/100, and this is still stage 1. But would you like?
Mother is deteriorating.
Yeah. So
mother is
increasing.
deteriorating.
Yeah, but we can follow up after a week.
Well, a week.
Yeah, but again, after 1 week, she is still stage 1, but now there is minimal mitral ascites and this thing. So
she should be delivered.
She should be terminated.
Yeah. So the message is, whatever may be the protocols, whatever Barcelona says, or whatever
overall maternal
says,
condition,
or whatever your radiology says that this is still stage 1, maternal condition supersedes everything, and this is
mother first.
Yeah, mother first. And the last case sent for an anomaly scan, 25 weeks 1 day, and the dates were corrected, and the 90/20 scan, she's come directly at 25 weeks 1 day to us, and we find that, of course, the estimated fetal weight is less than the 3rd centile. You have an absent diastolic flow in the umbilical artery. MCA, of course, is showing a little high low PI. There is absent diastolic flow. She's 29 weeks thing. So would you, 25 weeks 1 day, absent diastolic flow, MCA 5th centile, estimated fetal weight is less than 5th centile. This is what stage now?
Stage 2.
Stage 2.
This is stage 2 and 25 weeks 1 day, right? So definitely no question of delivering, but when would you like to follow up? Stage 2.
Twice weekly.
Once in a...
Yeah, bi-weekly. Okay, Pratma is back. Okay, fine. Now 26 weeks, 4 days. As I said, you tell them after 3 days, they come after 5 days, 6 days. There is still absent diastolic flow. This is still stage 2. Now, what next? Would you like to?
Still will continue, sir. We will continue monitoring.
Okay, 27 weeks, 3 days. Ductus venosus is still normal. Still stage 2.
Stage 2 will continue.
28 weeks, 4 days. By this time, the patient became very confident. Unnecessarily, this guy is calling me after every 3 days and taking 2,500. Now let me go after a week directly. By NST, but then fortunately, always remember when we use NST and both, it is always better not to do them on the same day. I always say that, okay, even if you want to do a weekly Doppler and an NST also, you may do a midweek NST and a weekend Doppler, or a midweek.
The 3rd day.
By that, what we are trying to do is, we are not climbing one floor directly, we are checking in between also, so in some form or the other. So umbilical artery is still, absent diastolic flow. What next?
Still continue.
Still continue to 1 week more.
30 weeks. At 29 weeks, NST was reactive. Reversal of end diastolic flow.
Ductus is deteriorating.
Ductus is not reversed.
Ductus is not.
What stage is this?
Stage 3.
Stage 3.
Will you deliver?
Still continue.
Better to deliver,
30 weeks.
Better to deliver.
30 weeks.
We need to deliver.
Better to deliver.
Better to deliver. यहाँ तक आने के बाद, no, you don't have the guts to really.
You don't expect more from this baby now.
Yeah. So
30 weeks is enough.
A fetus can pull on with an absent end diastolic flow for a long time, But reverse end-diastolic flow in umbilical artery indicates adverse outcome, and after 30 weeks, it can be predicted for stillbirth, and this has more risk than prematurity, hence early delivery is justified. So to identify a small fetus, do Doppler, distinguish between FGR and constitutionally small, stage the FGR and plan surveillance, and then decide on when to deliver based on protocols. An objective protocol-based approach to decision-making is now validated. Ductus venosus evaluation is the cornerstone for when to deliver in early onset FGR. The CPR is a critical index in late onset FGR, but yes, we use it for putting the patient into closer surveillance. Scans at 36, 37 weeks and 30, 32 weeks, along with Doppler, are becoming increasingly justified even in the low risk group. So keep calm and follow protocols. I never end my talk on anything on FGR without this poem, which was written by an unknown resident in Dublin way back in 1800 something, that I am a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my doctor get me out. And in addition to this is neither too premature nor too hypoxic. Thank you very much. Thank you, panelists.
Thank you. It was very interactive, and I most like the fire and the floors and the ladder of that gestational age comparison. Very beautiful. Thank you.
Thank you, sir. Thank you.
Wonderful session.
Thank you.
Thank you.
I was waiting for this the FGR panel moderated by you, because Sujit has praised a lot that for SFM you don't take anybody else. You just request sir will say yes.
Also,
thanks for honoring the invitation.
Also, the example of the drivers not driving till the cleft. That was also a very good example.
Very beautiful.
Very.
It was long-standing invitation to Dr. Sani, but somehow by webinar it came through. Thank you.
Thank you.
I just request permission to leave. I have to attend another SFM meeting at 9:30. If you allow me, Pratna is there. She will take the questions, or the panelists will take the questions from there.
Yes,
Madam,
sir.
Thank you,
I
sir.
have your permission. Yeah.
Thank you again. Thank you very much.
I had a wonderful time.
Just accept a e-trophy from us, sir. Thank you.
Trophy.
I've taken it. Thank you.
Yes. Thank you all the panelists. Dr. Pratna Shah, Dr. Bharat Pawar, Dr. Vandana Gandhi ma'am, Dr. Praveen Shinde sir, Dr. Manish Rani sir. Thank you. Now we'll move over for our last session. Session 4, does abnormal cranial Doppler predict disability in infants? For this, we have as chairperson Dr. Rajiv Raneswar and speaker Dr. Pradeep Suryavanshi sir. Dr. Rajiv Rane sir, he is presently director at Apex Hospital, MBBS from VM Medical College Solapur 1979 batch, DCH from VM Medical College Solapur 1982, private practice in Aklu since 1982. Very cooperative, very always guiding us, all the juniors. Over to you, sir.
Thank you, ma'am. Our next speaker is Dr. Suryavanshi. Dr. Pradeep Suryavanshi is one of the eminent neonatologists of our country. At present, he is a professor and head of Department of Neonatology, Bharati Vidyapith University Medical College, Pune, head of Department of Neonatology and Pediatrics, Sahyadri Hospital, Pune, chief patron and consultant neonatologist at Novel Hospital, Pune, mentor to Department of Pediatrics, BLD University, Bijapur, visiting consultant neonatologist at Sasun Hospital, Pune. He is also mentor to so many neonatology units in Maharashtra and out of Maharashtra. In Maharashtra, in Pandharpur, Karad, Jalgaon, Satara, Kolhapur, Ahmednagar, Solapur, and out of Maharashtra in Indore, Jaipur, etc. The topics given to Dr. Pradeep Suryavanshi is: does abnormal cranial Doppler predicts T-severity in infants? Over to you, Dr. Pradeep Suryavanshi.
Thank you, sir. Am I audible?
Yes, sir. I'll share your PPT, sir. Just a minute.
Thank you. Thank you. Thank you. Yeah, can you please share my PPT, please?
Yes, sir. Yes, sir.
Yeah.
Over to you,
All right.
sir.
So, fine. Can you just make that mobile? I'm not to responding to mobile.
Manisha, make it a slide.
Just a minute. Yeah, slide should be better for me because this is just yeah.
Third option on the top.
Yeah. You need to first share the desktop, and from desktop, then you have to share the PowerPoint.
Done, sir. But just a minute, sir.
Please share
I'll do
first
from
your
the other
desktop
device.
and then, yeah.
Just a minute.
Yes.
Sir, screen over होते हैं.
I'll do just a minute.
Yes, please. Thank you.
Is it seen now?
No.
PPT is not seen. Yeah, now it's seen.
Yes.
Yes.
Yes, it's perfect. Yeah. I think good evening, everyone, from the Arcluge Obstetric and Pediatric Society. It's my pleasure to talk you after the wonderful sessions which are covered by the eminent team from the obstetrics and fetal medicine. Please, next slide, please. Next slide, please. Yeah, so what I'll do in the next probably 20-25 minutes, it's already quite late for us. I will try to cover some of the important aspects about the outcomes of the neonatal FGR babies which we encountered. We have gone through these slides. So can I go to the next slide, please? Next, yeah, please, Manisha, madam. Next slide, please. Next one, please. So we learned about the concept of the early onset FGR. Yeah, that's one. Just I want this one. So now one important thing I would like to previous slide, please. the ABG slide, please. Sorry. Yeah, this is the one. Now, once we see this slide, we will understand about the Doppler abnormalities and associated acidosis and hypoxia. What this slide emphasizes you that once you have evidence about abnormal ductus venosus Doppler, you are encountering the hypoxic insult in the form of acidosis. So one thing is important is that abnormal Doppler associations with a fetal hypoxia. Ultimately, fetal hypoxia, which we deal in the form of hypoxic ischemic encephalopathy. So this is the first important outcome we all need to understand, that the babies with a growth restriction with the abnormal Doppler, that mainly the ductus venosus Doppler, you will encounter severe acidosis. So these babies you have to be prepared in delivery room for active resuscitation. That's the first take-home message from my side. Next slide, please. If you see the survival of the FGR according to the gestation wise, the previous slide, please. Outcome slide. Yeah. Just wait, Dr. Manisha, once I tell, then please put the next one. Previous slide, please.
This one?
Yeah, that's
Yes,
one. Survival of HGR at the discharge. This one, that's fine. Thank you. So if we see, sorry about this chaos, because I'm doing this meeting from the very periphery of the Sikkim. Because of the request from the team, I'm just trying my best, but I hope we will all have a good number of messages about FGR. So if we see that these are the babies once we have less than 8 weeks. That's the first important stage. FGR, the counseling of less than 28, you have to be very cautious. The survivals of the less than 28 weekers still in Indian only. 28 weeker, then the outcomes are better. Definitely 32 weeker. I tell you that especially 28 week, you have definitely high morbidity. Hence, we have to be very cautious and careful about the counseling. When we talk about a late onset FGR, that is a more than 32 weeker, definitely we can be in a much better shape of the outcome in the form of morbidity and mortality. The outcome goes up to 70 to 80%, naturally more than 90% survival, and 10 to 20% about the morbidity. Next slide, please. Manisha ma'am, next slide, please.
This is a neutral.
Yeah, so this slide, so last slide we learned about the outcomes. Now, if you see the important Cochrane data, the Cochrane data shows that if you have the FGR, your outcomes with the abnormal Doppler, the mortality is around 11 to 30%. So that is the one which was the previous slide, but I think the slide has gone behind, but that's fine. The message I wanted to give that when you have abnormal Doppler, definitely the mortality goes high. And that is when you have abnormal Doppler between 24 to 32 weeks. Incidence of the fetal death is 10 to 30%. That's a very high incidence of mortality. So remember, early onset FGR, high mortality. Next slide, please. So once you have a baby of FGR, we all know the babies are naturally with the thin umbilical cord, the muscle mass is less, the subcutaneous patch tissue is less. There could be associated microinsulin like and in the asymmetric FGR, we have relatively large size of the trunk and extremities and the low pointer index. So these are the clinical findings, what we aim and we see about FGR babies. So these are the important factors what we are talking about, the clinical presentation of a neonatal FGR babies. Next slide, please. So this is important data about the outcomes of the FGR in the neonatal period. The commonest outcome, I told you that the early onset FGR, you will end up with a stillbirth also. So the baby is less than 28 weeks, you have a problem of stillbirth. Baby is less than 28 weeks, you have a neonatal deaths also. And those more than 32 weeks of late onset FGR, you have a high incidence of morbidity. And these babies also suffer from asphyxia. So important thing what we need to understand, the FGR, especially what we are talking about, the abnormal Doppler problems, high risk of stillbirth less than 28 weeks, high risk of the death less than 28 weeks, high risk of morbidity also in the babies less than 30 weeks or less than 32 weeks, and high incidence of asphyxia in these babies. So preferably the golden zone we are trying is that the above 30 weeks is a slightly better zone when we consider about the FGR. Next slide, please. The commonest factor what we need to understand, if we see, this is the most important slide of my talk. The commonest morbidity when we talk about the FGR, that's important, as I always talk as a triangle. These babies are prone for feeding problems, hypoglycemia, polycythemia, and jaundice. So any baby with a growth restriction in India, always be careful about the feeding problems, always careful about sugar monitoring, and these babies, most of them will require the phototherapy nowadays because we have started delayed cord clamping also. So growth restriction, delayed cord clamping, high incidence of jaundice, and high incidence of a need of a phototherapy in these babies. So I would request obstetric team and neonatal team that when you are talking about the babies with, especially the babies with a, even though without Doppler abnormalities, that means we are talking about the IUGR babies who are small, thin Indian babies. They also have issues related to jaundice, polycythemia, and these other ones with the absent or reverse flows, they will have associated more polycythemia. Need of the partial exchange is high, need of the phototherapy is high. So this is the most important aspect which we want to talk about, early morbidity. The preterm growth restriction, they suffer more from this morbidity. Next slide, please. So this is the study done by our team, which shows that this is the increment in phototherapy after adopting delayed cord clamping practices. I think you all know, Oculus team knows that we started this concept of the delayed cord clamping since 2016. So we compared the data about 2016 previously and 2016 after 5 years data. And what this data has shown by our team that the babies who have received the placental transfusion or delayed cord clamping, they required more phototherapy. When we compared with this one with a AGA, LGA, and HGA, the HGA babies required more phototherapy as compared to HGA babies. When we compare the HGA versus the growth restricted with the absent or reverse flows, those babies with the absent or reverse flows, they require more phototherapy as compared to the babies who are playing HGAs without any flow problems. So that was a study published in Journal of Neonatology in 2021. It's freely available. You can go through that one. Next slide, please. So what I already mentioned is that the hypothermia, hypoglycemia, neonatal jaundice, polycythemia, these are the important complications as most of these FGR are encountered. When we talk about the babies less than 32 weeks, especially less than 30 weeks, FGR with the flow problems, these babies are prone for severe BPD, high risk of intra-arterial hemorrhage, definitely immune dysfunction, and high risk of infection. So what we are dealing here is that multi-problems of the growth restricted babies. Hence, we have to be very cautious about feeding problems, that is necrotizing enterocolitis. They are very prone for necrotizing enterocolitis. Hence, we always avoid formula feeds for growth restricted babies. If you give formula for growth restriction with the flow problems, you end up with a lot of time this NEC. These babies always end up with a chorioamnionitis with growth restrictions with this FGR in the form of a new BPD and high risk of PDA and IVH also. So these two important parameters we need to understand and consider. Next slide, please. So that's what I already have summarized. The two important factors which have a high mortality in the population of the preterm FGR. One is a NEC and second is a BPD. So friends, once you say that early onset FGR, and once you say that these have problems of a flow, you have to think about NEC and BPD in your mind. You have to counsel the families that these babies are prone for NEC, these babies are prone for BPD. And it is very proven that they always have very high incidence as compared to the routine babies. Next slide, please. Now, this is the largest study published about the abnormal Dopplers and NEC. What this study has shown that basically those babies with the abnormal UA, MC or DV, they have a high incidence of NEC as compared to the one which has a normal form of a growth restriction. So definitely what we discuss about the abnormal Doppler and NEC. Next slide, please. I'll not go to this study. Next slide, please. Yeah, this is the important aspect. Now we all know about the abnormal Dopplers, association with health syndrome, and these health syndrome naturally associate the release of the oxidative stress. That means the release of pre-oxidant radicals, and these pre-oxidant radicals, they damage the lung. And once you damage the lung, as we all know, we end up with high incidence of the new BPD. Hence, I told you the first problem NEC, and the second problem, high incidence of the new BPD, these babies end up. So first of all, you remember the triad, what I told you, feeding problems, hypoglycemia. Naturally, I told you about the polycythemia, jaundice, and need of the phototherapy. The second group of the problems I told you about NEC and BPD. These are the one we end up with the main problems. Next slide, please. Once we talk about the FGRs, we have seen in the first 3 days, they will be having abnormal hematological markers. Mainly, we encountered as a high incidence of thrombocytopenia in these babies. We do see the neutropenia in these babies, and naturally the polycythemia. These are the common problems about these growth restricted babies, especially we are talking about the one with the flow problems. So what we discussed, polycythemia, we discussed thrombocytopenia and the neutropenia. These are the three factors we need to see in these babies. Next. So this is summary slide about the last summary, means the data from the unit where we encounter that the previous slide. Yeah, when we see that there are high incidence of intrauterine growth, IUDs, neonatal death, BPD, NEC, hypoglycemia, jaundice. These are the problems of the FGR as short-term and long-term what we consider. Next one. Next slide, please. Now, let's see about the growth restriction in hemodynamics. Very, very important aspect. This is the recent study published by our team. Hemodynamics parameter after the delayed cord clamping in term neonates, mainly the growth restricted neonates, which is published in the International Journal of BMC Pediatrics this last month only. What we have observed that the babies of a growth restriction, they will have a lower cardiac output, that is the right ventricular output, left ventricular output, and SVC flow, as compared to the babies who are AGA. So the first group is a comparison about AGA versus HGA as the cardiac output. So we need to have our own data. That means we should have our own data about heart rate, cardiac output, or hematological parameters in these babies after delayed cord clamping. We don't have enough data. This is the largest study published so far, as 651 babies included in this study. And this study shows that the RVO, LVO, and SVC flow is pretty much basically higher in the babies with HGA as compared to the AGA. Next slide, please. This is the SVC flow data comparing between AGA and HGA on these babies. That is what I told you about the comparison data. Next slide, please. So what we concluded that the HGA babies had a high baseline heart rate and cardiac output as compared to AGA babies wanting a new nomograms for the heart rate and cardiac output for the HGA babies. One more study we have planned now on these parameters of hemodynamics, comparing these HGA babies with the HGA without flow problem babies and HGA with the flow problems, that is a growth restricted babies. That is the next study we have planned, and hopefully by next year we should have a data on that one. So these are the landmark study published in the BMC Pediatrics last month only from our team, and we are hoping for the new data and new nomograms for the heart rate and cardiac output for these babies. Next slide, please. This is one more study published by our team in 2014, is about cardiac output in the growth restricted babies. So these were the previous was after delayed cord clamping. This was the era of 2014 where the delayed cord clamping was not done. So when we saw about this cardiac blood flow in a stable babies in a HGA, we compared this HGA with the symmetric and asymmetric HGA, and we have compared with this HGA versus HGA. Again, the same data we encountered that these babies have a high incidence, high cardiac output as compared to HGA babies. And that's what we said, that we need more data about these babies. Next slide, please. This is the recent study published this month now, only 1 week prior. This study has published by our team. Echocardiograph findings in the form of ventricular function in a stable term HGA babies. So what we have measured the right ventricular systolic function, left ventricular systolic function, right ventricular diastolic function, and left ventricular diastolic function in a growth restricted babies. What we observed that the systolic and diastolic, all these ventricular function are hampered in a HGA babies and mainly in a growth restricted babies, mainly the babies with absent or reverse flow. This was the article published in Italian journal of Ultrasound, and that is what our team is doing, a lot of work on the ventricular functions in these growth restricted babies. Next slide, please. These are the functions, basically the left and right ventricular diastolic functions. Next slide, please. So these is the parameters of what we compared. I told you the right ventricular systolic function, right ventricular diastolic function, left ventricular systolic function, and left ventricular diastolic function. These are the parameters we have studied, and these parameters are hampered in these babies of growth restrictions. And when we compared about the babies of HGA versus babies with the flow problems, these are more hampered in the babies with the flow problems. That means the babies with absent or reverse flows, they are inner issues related to the abnormal hemodynamics. What is the next study we have planned? Comparison of the hemodynamics between early onset FGR and late onset FGR. That is the next study our team has planned. Next one, please. Next slide, please. So I told you that the babies with the HGA have a mild to moderate dysfunction of systolic and diastolic ventricular function, reduced ability to adapt the postnatal life secondary to cardiac remodeling due to the chronic unilateral growth restriction. That was the conclusion our team has done from this study. Next slide, please. Okay, this is the recent study. I think, I don't know whether this study has been discussed previously in the last 3 hours, but this is a study called as a Strider study. People thought that if we give some medication to improve this early onset of FGR, and they thought of giving sildenafil. By giving sildenafil, we can think about vasodilatation in the placenta. And does this vasodilatation improves? This was the recent, just now in the European Journal of Pediatrics, this study has published that actually the mother who has received the sildenafil for this early onset of FGR, the babies are ending up with severe form of neonatal pulmonary hypertension. That means the babies have a reverse flow. That means baby has a vasoconstriction. Hence, this study has been stopped in the interim analysis because of the adverse neonatal outcome. And the neonatal outcome is in the form of pulmonary hypertension and high mortality to the mothers who have received the sildenafil. So this is the outcome of the Strider study, and which is very worrying. Hence, now people have stopped giving sildenafil to the mother. They're hoping that this sildenafil is going to do as vasodilatation, but this is not the good thing. Next slide, please. Now let's discuss about the growth. In the few slides about the growth of the fetal growth restricted babies, mainly the absent or reverse flows. Now what we all know is one thing is clear: if a child is born as a preterm AGA, they are going to catch up. But if the child is born as a preterm HGA, they are going to be naturally less weight, less height as compared to AGA. That is one thing clear. And if the child is a preterm with an absent or reverse flow, they are going to be behind about the growth parameters, all the parameters. And hence, we have to be very cautious about these. These are the three groups. I told you the preterm AGA, the preterm ethnic HGA, that means mother is small, families are small, baby is going to be born small, and the preterm with a growth restriction, with the flow problems. They are the one, they suffer more in the growth problems. Next slide, please. One of the important concepts, what we all know, is called as the metabolic syndrome. That means if I am born small, I should remain small. I should not put on too much weight. I should not put on think about all those parameters, because these child, they are prone for insulin resistance, they are prone for hypertension, they are prone for diabetes, and they are prone for cardiovascular disease. So remember, the babies with the growth restrictions, with the absent of reverse flows, they should not put on weight. The obesity is the biggest culprit for them, and with that obesity, they end up with the problems of naturally as the hypertension, diabetes, and cardiovascular disease in the form of myocardial ischemia, myocardial infarction. So that is called as a fetal origin of therapy, or the Barker's hypothesis, or the metabolic syndrome. So please remember that, be careful. These are the babies between 4 to 10 years, especially 4 to 8 years, they develop the insulin resistance. And we should be very careful about weight patterns, weight gain patterns of these growth restricted babies between 3 years or especially 4 to 8 years. And we don't want too much weight gain for these babies. They should remain thin and tall. That's our expectation. That is about metabolic syndrome. Next one. Next slide, please. Now, let's discuss about the long-term neurological problems. That babies who are going to be born as absent or ears closed, the risk of cerebral palsy is 1 to 3 times more than the general population. That's about cerebral palsy. If you see the MRI of these growth restricted babies, next slide, please. If we see the MRI of these growth restricted babies, their MRI, the volume about the cerebrum as well as cerebellum is a small as compared to AGA. And these babies develop the cognitive delay, speech delay, motor dysfunction, and impaired school performance during adolescence. So yes, we have to be very cautious. We have to be very, very careful about monitoring these babies. Don't expect them to behave like AG babies. Don't expect them like behaving like a preterm AG.
Sorry to interrupt you, sir. It will be better if you stop your video.
Hello?
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 Sir, there is some range network problem from your side. It will be better if you stop your video.
Hello?
Yes, sir, you're audible now.
Am I audible
Hello?
now?
Yes, sir, yes, you're audible.
Hello?
Yes, sir, you're audible.
Dr. Manisha, am I audible now?
Yes, sir, you're audible.
Sorry about the network connection. I already mentioned in my session that
Yes,
I
sir,
am
you
sitting
can
in
just
very
stop
remote
your
part of
Sorry
video.
to interrupt you,
It will
sir.
be better.
Actually, one small request to you. I know you are in other area. Sir, if you can stop your video, then your
I
voice
have
will
done
be
that.
more clear.
I did stop. Yes, I did stop my video.
Yeah,
Yes, sir,
now
better
your
now.
voice is much clearer, sir. Thank you, sir.
Okay,
Please continue,
video
sir.
is stopped now. Yeah, video is stopped now. So I will just revise 2 slides, or just probably I'll just revise for the people who have missed
Sir,
those
your
ones.
voice is much clear now, sir. Please continue, sir.
Thank you. Thank you. So the 2 things I'll revise: the long-term neurological outcome. These babies are 5 to 7 times high risk from the cerebral palsy point of view. And if you see the MRI pattern about these preterm FGR babies, where we have issues related to the small brain size volume, small cerebrum, small cerebellum, they end up with a cognitive delay, speech delay, motor dysfunctions, and school performance. So that is what we are trying to say, that the babies with I discussed about the growth parameters. We don't want these babies to put on too much weight. We said that babies should not become obese. Babies should not develop insulin resistance. They should remain tall and thin. And these babies develop hypertension, diabetes, and myocardial infarction. That's metabolic syndrome we discussed as the growth. But the long-term brain-wise, they have very high risk of cerebral palsy. At the same time, cognitive impairment is very high. Hence, we have to be very careful. Next slide, please. Next slide, please. So that's what I already covered. Next slide one. Next one. I'll just cover a few slides now. Yeah, next one, please. Yeah, this is the one, probably the what I'm trying to say, that the growth restricted babies, if you see the small head circumference, less education, lower socioeconomic stage, they have a poor short-term memory, low IQ, more restlessness, they are more timid, and naturally they have neurological impairment more, and more initiatives where the problems will suffer. So what I'm trying to say here, I think I will for this point I will stop here, but I will just try to summarize what I'm trying to say, that when we talk about the FGR with the flow problems, dial emergency in delivery room. because these babies are prone for hypoxia. That's the first message I wanted to give you. So the babies with the growth restriction, they have acidosis, hypoxia, be ready in the delivery room. Give a proper counseling in the form of mortality and morbidity. Less than 28 week, high mortality. About 32 weeks, okay, good survival, but still morbidity is there. That is the first message. The second message I wanted to give you that, what I told you that, the triad, feeding problems, hypoglycemia, first problem, polycythemia, jaundice, neonatal hyperthermia requiring phototherapy, and hypothermia. These babies suffer, all babies will suffer these problems. Then we discuss about the issues related to the, what we discuss is related to important thing, NEC and BPD. These are the babies who develop NEC and BPD quite frequently. And what we discuss is the growth problems, metabolic syndrome, and long-term cognitive delays. These are the problems we encountered when we are talking about the growth restricted babies. Manisha ma'am, you can stop the video. You can stop the sharing. Any questions we can discuss? I don't want to go ahead with the other slides. I think I'll stop here. The hemodynamics is which, yeah, you can stop that sharing.
Yes,
the hemodynamics is the area. Hemodynamics is the area which we have encountered in India, and we are doing a lot of studies. I have shown you the studies related to hemodynamics in the form of, I already mentioned about the delayed cord clamping and hemodynamics in growth restrictions, hemodynamics, cardiac output in the growth restrictions, hemodynamics and ventricular function in growth restrictions. And now I told you about comparison between absent and reverse flow, comparison between early onset and late onset FGR, hemodynamics. That is our area in the India, what we'll do. Sorry about the connection, and but I try to cover the summary messages. Hopefully we can able to see that. The madam can put the PowerPoint presentation in the form of PDF in your group. That can be done, but all of you know that, yeah, all of you know that every obstetrician, please keep the phototherapy in your unit, because all these growth restricted babies will require phototherapy. Hence, you have to be very cautious about these and always act fast. Some babies will require partial exchange. Hence, backup of NICU is important, and the babies less than 32 weeks always need of NICU. Hence, you should have a good NICU backup. With the help of the good team, you have good outcomes in these babies also. Yeah, any questions, please let me know. We can discuss the questions.
Yes, thank you. We'll have a few words from Dr. Rajiv Rani, sir, as a chairperson. So please unmute yourself.
Hello.
Yes, sir, you're audible.
Okay. Thanks, Dr. Suryavanshi, for enlightening this topic, because so many things you have mentioned. When the cranial Doppler is abnormal, how to predict the abnormalities in the babies. Those are useful for pediatricians and neonatologists who are working in the neonatal units. Thanks. And thanks, AOGS, for giving me the opportunity for sharing this section.
Thank you, sir. Just a small from Aklus Obstetric and Gynec Society to our speaker, Dr. Pradeep Suryavanshi, sir, and our chairperson, Dr. Rajiv Rane, sir. Now we'll have a question answer session. All the speakers and panelists are free to answer. Is Dr. Pratibha Valdeva there? There's a question to Dr. Pratibha Valdeva, ma'am. Okay, any gynecologist from us, from our panelists can answer, our speaker. Dr. Sudesh Doshi, sir. There's a question from Dr. Ranjit K Kerser then.
No, he is also left.
No, sir is there. Kerser is
Ranjit
there.
sir is there, ma'am.
Okay.
Sir is there.
So there is a question from audience about role of vitamin K, Maxels, Dexa for IUGRs and oligos. Exact dose.
Actually, in my practice, what we do is, if we foresee the complications of prematurity, FGR, and we definitely foresee that we are going to have early termination. So the standard dose of metresol what we use before 32 weeks of gestation is 12 milligrams, like 3 ampoules of injection metresol intramuscularly 12 hours apart. That is for the release of surfactant. The counter of the second part of this question was, what is the dose of, you mean to say, Maxel? For neuroprophylaxis, it is the 2 gram of injection Maxel to be given 12 hours apart for dosage of 4, like in the morning and evening, and next day morning and evening. So that is as far as Maxel is concerned. So Dexa, presently I am not using Dexa as a stimulator for release of surfactant, but any of the audience or faculty has a, experience, can share with them. Ideally, what I use in my practice is injection betnesol and injection Maxel, neuro and chemo prophylaxis.
Thank you, sir.
Can I add here, please?
Yes.
Yes, sir. Yes, sir.
Yeah. Thanks for the question. I missed the initial part, but one of the important aspects where I think we have prepared Government of India guidelines in 2015 as a part of the member. One of the important aspects is that the molecule available in India is only valid molecule is dexamethasone.
Okay.
The dexamethasone molecule, which betamethasone molecule, which is available in India, is not the pharmacokinetic is the right molecule for antenatal stimulation for the surfactant synthesis. So as you all know, if you just open the Family and Welfare Center Office, Government of India, Ministry of Health website, you will get the PSCs also. Government has requested to give dexamethasone as a simple, what we are requesting 6 milligram intramuscular 12 hourly for 4 dosage. So my humble request to all my colleagues, please use dexamethasone, which is the correct molecule available in India. In the West, betamethasone phosphate acetate is available, which is not available in India. Hence, please use dexamethasone. That is the first request. The second request, if you are planning to use the Maxel, which is again, we have done the review and published in Journal of Perinatology in 2014. Please use the Maxel of 4 gram over 30 minutes. Have a neuroprophylaxis because that dose is studied to reduce the NNT, number needed to treat in the form of cerebral palsy, as now is a 43. When we give less dose, then the number needed to treat required is 63. Hence, the various societies, one is Australian Society in 2007, Canadian Society in 2008, American Society in 2012, European Society in 2013 has recommended 4 gram of loading dose given over 30 minutes and then give 1 gram till the time, every hour till the time delivery happens. Naturally, vitamin K for all the babies, which is after the birth, which is important is vitamin K1. Don't give K3. K1 is the one which is the most important because with the K3 you will have more hemolysis and jaundice. So please use that one. These are the 3 messages I wanted to give.
Dr. Pradeep, can you please elaborate regarding this dose of dexamethasone?
Yeah. So the dexamethasone dose is very simple. It's a one important thing is that if you decided to have an elective section, suppose I want to have elective section today morning, or suppose today is Friday morning, then what is the need is that we all know that dexamethasone should be given 24 hours after the last dose and 7 days prior. So once I want to give dexamethasone, suppose I started dexamethasone today morning at 8 o'clock, the second dose will come at 8 p.m. Third dose will come at 8 a.m. the next day and 8 p.m. as a fourth dose. So 6 milligram intramuscular 12 hourly. After the last dose, please wait for 24 hours. suppose that's what I'm trying to say. Suppose I started giving dexamethasone Thursday morning. I have given 8 a.m. my first dose. Thursday evening, 8 p.m. second dose. Friday morning, 8 a.m. third dose. Friday evening, 8 p.m. fourth dose. Don't do the section on Saturday. Section on 8 a.m. on Sunday would be the better choice. So after the last dose of dexamethasone, if you get a time, please give 24 hours, because that 24 hours will give you the maturation, the release of surfactant. So the dose is 24 milligram, and that has to be given over 48 hours. That is more important thing.
Okay. Thank you.
Yeah.
Thank you, sir.
Would you like to advise the dexamethasone even at the full-term baby, if we do an elective section for any other reason other than FGR?
Okay. I'll just comment on the few points about this dexamethasone now as a discussion of dexamethasone. One which is a very clear-cut indication of dexamethasone is 24 weeks to 34 weeks. That is very well documented. So that is 24 to 34 weeks. The second indication is basically the late preterm, 34 to 36.6. That is late preterm, that is dexamethasone. If your team is managing periviable births, 22, 23, 24 weeks, that is also dexamethasone. If you're planning elective section for early term, that means 37 to 38.6 for maternal region. If you are planning early for elective section for early term, 37 to 38.6, then dexamethasone, yes. But if you are planning emergency, if you are planning the term that is 39-40, no dexamethasone. So only dexamethasone for elective term where you think that baby will have a benefit in the form of reduced respiratory morbidity. That time only early term, not the full term. That is what we are discussing.
And sir, about the repeated doses, it shouldn't be repeated, right? Given or
okay, repeated. I will. Dr. Revati, just give me 1 second. Please avoid weekly dosage. So there is no recommendation of weekly doses of dexamethasone. What is recommended is rescue course. Now, what is a rescue course? Suppose the lady comes to you at 26 weeks and she's in preterm labor. Somehow you have given the full course of dexamethasone, but by God's grace and by good care by you, she hasn't delivered. Fantastic, we are happy. But again, she comes at 30 weeks. And at 30 weeks, you are sure now she's going to deliver. Then you give full rescue course. That means full course of dexamethasone. That is called a rescue course. The rescue course can be given a gap of 15 days. Again, full course. Don't confuse with the dose and course. Course is 24 milligram. Always give 24 milligram. That means 6 milligram intramuscularly, 12 hourly, 4 dosage. That is a full course, and that has to be given. That is.
So can we give it as 12 milligram 2 doses? Does it make any difference giving 6 milligrams?
Yes. It does make a difference, because the pharmacokinetics of dexamethasone, which is studied in all studies, basically is 6 milligram. Suppose now I am traveling today and I said, I don't want to have a motion sickness. Can I take 2 tablets of omine instead of 1 tablet so that I will not omit today and I will not omit tomorrow? Is this feasible? No, it is not feasible. No. So please, we are to respect the pharmacokinetics, pharmacodynamics, and the studied dosage. And these studies dosages are 6 milligram 12 hourly, not 12 milligram 12 hourly. What happens, people have done 8 milligram also as 3 doses, 8 milligram 6 hourly also. People have tried 12 milligram 12 hourly also, and people have tried 6 milligram 12 hourly also. Out of that, 6 milligram 12 hourly is a better dose and better outcome.
I think there are many doses of dexamethasone, and this is the 3rd, 4th protocol I'm hearing. 6 milligram 6 hourly, 6 milligram 8 hourly, 8 milligram 6 hourly, 12 milligram 12 hourly, and just now you told 6 milligram 12 hourly 4 doses. So overall 24, but there are many types. I don't know. Recently, with just I want to share this. Recently, one of the patient asked that steroid doses of one of the gynecologists from Bidar or something from Karnataka told every Saturday 12 milligram dose. So
that shouldn't be new. What happens? Yeah, what happens in India? Everybody feels that the practice which I'm doing is the one which is feasible for patient. That is acceptable for that patient. But what we are thinking here is evidence-based practice. What we are talking here is the Government of India guidelines. Hence, please download one page, Government of India guidelines, antenatal steroids for fetal maturation. And the people always now ask as government guidelines or society guidelines. So government guidelines are very clear cut. 6 milligram, IM 12 hourly for 4 dosage. Just go to the family and the central welfare's website. We will get that one. Or if you want, I can put in the group tomorrow about antenatal steroid guidelines also.
Yes, sir,
the group
please.
which you
That
guys
would be very
I can put that on the group also.
Yes, and earliest, how earliest can we give? I mean, is it
22, 23,
22 week is the
24?
cutoff?
Yeah,
Okay.
22. Those parents in Pune city, the 22 week also they want. I don't have choice. Then I have to give the thing. But good thing is 24 to 34. That is the best thing.
Is there any harm of giving it earlier? Is there any harm? Documented harm?
There is no documented harm for 22, 23, 24 weeker in the West culture. Now it has become routine practice for the 22, 23, and 24 for West, and hence they are giving for all. There is no documented harm at present moment.
Okay, sir. And also regarding Maxsurf, I mean, we have been giving us, as you suggested, 4 grams in 30 minutes. But later, we were giving infusion as a 5 grams in 500 ml. That is 1 mg per hour. That would be come as a dose as an infusion pump. But till the time of delivery.
Yeah.
Okay.
See,
okay.
Very important thing is that you should not give as a fast dose. You should give over the time duration. That is the most important thing. As long as you are giving that over the 1 hour, that is the best thing, because that will give you, baby will not develop the basically respiratory depression. That is most important thing.
Yeah, by infusion, as per my experience, by infusion pump, it becomes very easy to titrate and to monitor basically.
Yes.
Yeah, thanks a lot.
Only just I would like to add, if just a moment, if your patient, as Revati was saying, if your patient has got hypertension and you are giving injection Maxsurf, so don't have a combination of Depin and Maxsurf.
Yeah, both.
So that is going to create, either you have to be very cautious when you are giving like Maxsurf and you are giving especially beta blockers, I would say. So have that in your mind that so you need to be very careful when you are giving injection Maxsurf. So calcium channel blocker should be avoided.
Yes.
Okay. Thank you.
Thank you, sir. Next question is, how much maximum alamine or hermine or aminoven infusions can be given? Vandana ma'am.
I think sir has pointed out that there is no role of such infusions just now. So
I would like to
skip all. These are all gimmicks made by pharma companies, and we should not fall prey to that. That is the
first we should understand that the pathology is diagnosed, means pathology has occurred earlier. Once the placenta is damaged, you label it as an FGR. Then you are not going to revert it by giving anything pouring on the patient. This is the problem, that we cannot anticipate which patient will go in IUGR. Once placenta is damaged, it is not going to be in reverse way. So this is all empirical.
We should give.
Also, I would like to ask about the take-home message about sildenafil in IUGR from Suryavanshi sir. I think one missed on that part. Sildenafil.
Okay. Dr. Rane, see what happened. What the people have thought that if we give sildenafil to the mother, people thought that sildenafil act as a vasodilator. In neonatology, we use a sildenafil as a vasodilator for pulmonary hypertension. It's a very well known. So people have started using sildenafil to the mother as a 5 milligram dose, and they thought that this will act as a placental vasodilatation.
Yes,
But
it had come up, and I had also tried actually.
Yeah, I'll complete that and then I'll come back. What happened actually? What happened that these are the mothers who have received sildenafil. Their babies have ended up in NICU with the pulmonary hypertension, which is called as a reverse action. What happened? Reverse action. You have giving sildenafil, baby got adapted to that, and you suddenly stop that sildenafil to the mother. That means baby is born. And once the baby is born, instead of baby with a good thing, baby has worsened as the pulmonary hypertension. So the baby has developed as a reflex pulmonary hypertension because there is no vasodilator now, and they have gone to the vasoconstrictor. So this is called as a stridal trial. This stridal trial, they have to stop before recruitment. That means they have completed only 50% of recruitment. And what they saw that because of the high incidence of the pulmonary hypertension in the babies, they said that this is not good. Please stop and don't give the sildenafil to the mothers.
Okay. I was wondering because why pharma companies stopped, recommending it for IUGR. When I had used it for patient, 1 or 2 patients, they developed a hypertension rather. So even I had stopped it. Thanks a lot, sir.
Any other questions?
I guess all questions are answered.
Are over, yes, and were everything, all the sessions were very interactive.
Covered. Yeah.
So we'll now move over to Dr. Ranjit Rani.
Yes.
For vote of thanks.
Thank you. Yeah. Actually, almost everyone has left. But thank you. It was an excellent lecture. This webinar, I must say. And thank you for all the esteemed speakers, panelists, and chairperson for sparing time for this wonderful session. IUGR, I must say that it is very commonly encountered case scenario, but very less known about it. And today I was traveling from Pune to Akluz, and it was an enlightening journey for me. I must go and read new protocols, and everything has to be reread again. But I must say it was really very enriching session. And thank you, our President, Dr. Priya ma'am and Vandana Gandhi madam, for taking a lot of effort for gathering such a good set of expertise in it. And thanks a lot. I must thank our clinical secretary, Manisha, for taking a lot of efforts. And I know what is the pain behind arranging everyone and contacting everyone. So she did the job wonderfully.
Thank you, Riddhi.
Thank you, ma'am. Thank you, ma'am, from the Water Personal.
Yeah, thanks.
I'm going to thank. I'm thanking you in the last for giving us the academic and the digital platform.
Yes.
Thank you. Thank you.
One request to Dr. Priya madam is just to put this recording on the YouTube and give us a link so that anybody, if anything has missed out, will be able to get the knowledge, especially from Dr. Vimal sir. So it was really fantastic to have the tips from him. Yeah.
Amazing discussion.
Thank you.
Good night.
Thank you. Good night.
Good night,
Okay,
everybody.
Good night, everybody.
Thank you.
Bye.
Thank you all the water persons. I have talked with them all.
Thank you all esteemed faculties. Walter Bushnell is always ready and committed to provide all technical supports for this as scientific feast, ma'am. Thank you, ma'am. Have a good night.
Thank you.
I was always behind you, Yogendra. Thank you.
Right, ma'am. Thank you, ma'am. Most welcome.
And please send the link as sir has mentioned. Recording.
Sure. The YouTube link is already shared.
Ma'am.
I will again reshare in the group.
Please share it again.
Right. Just after.
You.
So I will
Yeah,
close
ma'am,
the
I
stop.
will share with you.
Right.
Yes, thank you.
Okay. Good night, everyone.
Good night.
Bye.